तो हाँ, तो जो सिर्फ होटल का है वो अमाउंट 10,000 प्लस टैक्स पर डे का है सर ये। तो आपका 22 से 24 है। अब रजिस्ट्रेशन का अगर आपको देख भाई,
हेलो हेलो। हेलो हेलो।
पेमेंट लिंक जो उधर है इसलिए होता है सर क्योंकि पेमेंट का ना ट्रांजैक्शन की डिटेल होती है कि किसके नाम से पेमेंट आई है। काउंटर में नहीं है, काउंटर में नहीं, होटल को हम पे कर रहे हैं ऑलरेडी। होटल को मैंने पे करवा दिया है सर। आपकी वाइफ का जो स्टे है ना उसका पे मैंने होटल को करवा दिया है। होटल में पेमेंट करिए, मैंने पे कर दिया।
हेलो 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 हेलो। आ रहा है मेरा आवाज? आ रहा है ना? खुशहाल खुशहाल।
Dr. Anush for making a part of this study and giving me the opportunity to present this study. The study is prevalence of undiagnosed anemia in Indian population. Principal investigator Dr. Anush Maheshwari here, co-investigator Dr. Priya Ma'am and Dr. Satish Ma'am. So, support from Mediva. So, this study was a pan-India study representing all the zones, north zone, south zone, central zone, east and west zone from India. These are the list of the contributors for the study. So we'll start with the introduction, then results, and then conclusion. So anemia is a condition in which hemoglobin concentrations or red blood cell numbers are lower than the normal and insufficient to meet an individual's needs, and it affects nearly 1/3 of the world's population. This might result in the most common symptoms like weakness, fatigue, dizziness, and shortness of breath. The most common cause being nutritional deficiency, more commonly iron deficiency, and also B12 and folic acid deficiencies are also most common causes. Other common causes, less common causes include immunoglobulopathies and chronic infections like HIV, tuberculosis, malaria, and parasitic infection. The study rationale was the study was designed to ascertain the overall prevalence of anemia, undiagnosed anemia, and associated factors among patients in India. Definition of anemia: according to WHO, anemia is defined as hemoglobin levels less than 13 grams per deciliter in males and 12 grams per deciliter in females. Mild anemia is hemoglobin levels between 10 to 13 in males and 10 to 12 in females. Moderate anemia is 8 to 10 grams per deciliter, and anemia hemoglobin less than 7.9 or less is considered as severe anemia. Primary objective of the study was to look for the prevalence of anemia and patients receiving a physician screening in India. And secondary objectives were to determine the prevalence of undiagnosed anemia in patients receiving physician screening and also to analyze the patterns of signs and symptoms of anemic population. So the study was a descriptive cross-sectional study spread over a period of 6 months. In India, all patients who provided consent to participate in the study and also agreed to use randomized data for research purposes. Data was planned statistical analysis was done using Spaces software. Various statistical tools were used and p-values were considered less than 0.01 was considered statistically significant. So the study was approved by ethics committee of the Indian hospital. It was approved on 1st of February 2023. So total of 5,670 patients were enrolled, out of which 833 patients were excluded because the hemoglobin parameter was not available. Another 893 patients were excluded because the data was available, but history of anemia was not captured or the data was. So the final sample of 3,971 patients was analyzed. Baseline characteristics, here you can see. Nearly 60% of the population was aged more than 45 years. They were middle aged to elderly. And gender-wise, male to female gender was almost similar to the population. You see, more than half of the patients BP were under optimal control, that is BP less than 120 systolic and less than 80 diastolic. 36% had high normal BP and 8% had grade 1 hypertension. If you look at BMI, nearly 66% patients were either obese or overweight, and obesity prevalence was 46% in overall population. And coming to social habits, study population, most of the patients had no bad habits like alcohol consumption, chewing tobacco, and smoking cigarettes. Neither they did have any good habits. Only 9% of the patients were exercising regularly. So comorbidities, diabetes was most common, seen in 2/3 of the patient. Hypertension is seen in 1/3 of the patient, and hypothyroidism in 10% of the patient. Diabetics, most of them did not have any complications. So anemia, if you see, total of 371 patients, nearly 30% patients had history of anemia. That means they had previously history of anemia or were diagnosed with anemia and referred to the physician, or maybe on routine checkup they were found to have. And if you see among history of anemia, 26% patients still had anemia on, and if you see 70% of patients had no history of anemia, and when HB levels were normal, that means this 30% had low anemia, and this 33% patient had no anemia, and remaining 37% had undiagnosed anemia. That means they had no clue that they had anemia, or they did not have any symptoms, but on investigation they were found to be anemic. And overall prevalence of anemia in our study population was 63%. If you see gender-wise, female patients had more anemia, significantly more anemia when compared to male. Even undiagnosed anemia and diagnosed anemia was more in females when compared to male, and this is a known fact that females have more anemia. And if you see age group, patients more than 55 years had more anemia when compared to younger population. And patients, if you see this in younger population, the undiagnosed anemia was more common, and in elderly population, diagnosed anemia was more common. That means they had some comorbidities for which they used to go frequently for the regular checkup, and they were diagnosed to have anemia. Again, if you compare BMI groups, those who were underweight had significantly higher anemia when compared to those who were overweight and obese. And undiagnosed anemia also was more common in underweight individuals. Coming to BP groups, patients who had optimally controlled BP had more of undiagnosed anemia, and those who had grade 2 hypertension, that means they had some comorbidities, they had diagnosed anemia. That means again, they were frequently on follow-up and on diagnosis, the routine investigation, they were found to have low hemoglobin. There was no difference between the prevalence of anemia in whether patient was diabetic or non-diabetic, but non-diabetic patient had more of undiagnosed anemia, and again diabetic patient had more known history of anemia. Severity of anemia, if you see, again females had more severe anemia compared to males, and among age group, if you see, severe anemia was seen in younger population. So young females, mostly because of in the reproductive age group and more of menstrual abnormalities, might have more of anemia. And moderate and mild anemia was more common in elderly population. So if you see BMI, again, severe anemia was more common in underweight individuals, and obese individuals had almost 50% of obese individuals had normal hemoglobin levels. Again, patients who were having good control of BP, severe anemia was more common. And if you see rural urban population, all three groups of anemia were similar in both urban and rural population. But if you see the severity, if you compare only the rural population, the severe more number of rural patients had severe anemia when compared to normal hemoglobin. And socioeconomic status, there was no significant correlation between the anemia and socioeconomic status. Again, pallor patient, one of the most common findings in patients with anemia can be the degree of pallor. The pallor was more common in patients with a increase in the degree of anemia, and the most common site or most better site to look for anemia is lower arteries. And coming to signs and symptoms of anemia, like weakness, fatigue, dizziness, body aches, decreased appetite, dyspnea, headache, pale skin, irritability, and poor concentration, they are significantly more in patients with severe anemia than those with normal hemoglobin levels. And if you see quality of life questionnaire, everyday tasks, difficulty standing for long time, feeling distress, difficulty walking, was again more in patients with severe anemia when compared to those with normal hemoglobin levels. Coming to distributive and hypertension, there was not much prevalence of anemia in patients with distributive hypertension. But you can see the severity of anemia was quite less in patients with hypertension and distributive. Maybe because of the frequent checkups, they might have got correction. So, if you see in type 2 diabetic patient, again the prevalence was more in undiagnosed anemia compared to diabetic patient, and in diabetic patients, diagnosed anemia was more common. Again, selective anemia was more common in patients with non-diabetic patients. This is a most important slide. You can see HbA1c levels were 7.9% in patients who had normal hemoglobin and 7.8% who had severe anemia. But if you see the fasting blood glucose and post-blood glucose, there was more in patients with normal hemoglobin when compared to severe anemia. This suggests that anemia can cause falsely elevated HbA1c levels in patients with diabetes. So, for our discussion, the burden of undiagnosed anemia is a significant public health concern. Efforts to address the undiagnosed anemia should be part of broad strategy to improve public health and access to healthcare services, with a particular emphasis on prevention, awareness, early diagnosis, and treatment. Several factors contribute to burden of undiagnosed anemia in India, that is high prevalence, lack of awareness, limited healthcare access, stigma and cultural beliefs, and nutrition challenges. So there are many programs by Government of India for prevention of anemia, like National Nutrition Control Anemia Program, weekly iron and folic acid supplementation, National Iron Pulse Initiation, Poshan Abhiyan, and Anemia Bharat. Again, this high prevalence of anemia in Indian population, more in females than in males. There are studies across India which has estimated that prevalence of 21.7% in men and 53.2% in men. That means earlier studies have also shown that prevalence of anemia is more common in females when compared to male. Systematic review and meta-analysis of nearly 8,500 patients conducted by Daniel et al. Revealed a very high pooled estimate of anemia of 68.3%. Male population was 63%. According to a report by WHO, anemia had a total prevalence of 23.9%, impacting a total of 164 million individuals within the elderly population. Again, anemia is more prevalent in underweight patients who are than in overweight or obese patients in our study population. So earlier studies have also reported that prevalence of anemia is more common in underweight individuals. The connection between obesity and anemia remains a subject of debate. Some studies are in favor of anemia being more common in underweight individuals, and some studies have shown they are more common in overweight and obese individuals. In the present study, anemia was more prevalent in underweight individuals, and this can be attributed to undernutrition, which is linked with lower dietary iron consumption and higher risk of anemia. And prevalence of undiagnosed anemia is less in patients with diabetes when compared to patients with no history of diabetes. We all know that anemia prevalence is more common in chronic diseases, including diabetes, maybe because of GI blood loss or decreased absorption of iron and interventions of diabetic drugs. But undiagnosed anemia is prevalence is high. This may be because the patients have more frequent visit to the clinicians, and they might be diagnosed with anemia and they might be given supplements to diet anemia. So to conclude, younger age groups, particularly females, have higher prevalence and more severe anemia. This is a cause of concern. There is a need for awareness, creation of preventive measures. Also need for a robust research that delves into underlying factors driving the higher prevalence and severity among the crucial youth, which is crucial to tailor effective interventions and policies. And undiagnosed anemia was more common in patients with diabetes than in patients with diabetes. And the severity of anemia also was higher in patients with non-diabetes. Again, this may be because of frequent visits to physicians. So there is the answer. Thank you. And this is just a preliminary data, so further more research findings. Yes, even this patient presented small micro GI bleeds also. this was a multi-center study. I don't know what about the other centers have it, because we have this data, and even in our center we have mentioned about the GI loss. Yes. And also we are looking for metformin use also, because metformin results in B12 deficiency. But this are all consecutive patients presenting to the clinic, whether they were diabetic or not, they were enrolled. So I don't think it's a confounding factor.
No, you are right.
Yeah, most of them are diabetic. Yeah, physicians are, yeah, like
Because the doctors who are practicing in this study participating, they are primarily diabetologists.
Yes.
So it is more likely that only people with diabetes will be coming to visit them. And so there can be a possibility of confounding.
What about the renal status? Because renal status is a very important aspect and impression on the severity of anemia. So I think that also can be looked into. What was the GFR like?
Nephropathy was not much common in this population.
No, it would not be common. What you can do is GFR, you can correlate with the severity of anemia.
Yeah,
That would be
that-
useful, especially you
We
had
have creatinine data, we can.
So, congratulations, Dr. Mohsin Islam, for a very nice initiative from the ACP India regarding this study. So, there are various studies already done. Which is not there already done.
Most of the findings are similar, but only one thing we have found is like undiagnosed anemia. This was a new finding what we got, and it was very high prevalence. That undiagnosed anemia, patients presenting to the clinic for some other condition, and then on investigation they were found to have autoimmune.
One point in my mind is that undiagnosed we have observed that in my seniors, especially women, 30 to 40% of them are diagnosed. And the same, that's how
Thalassemia treated.
So thank you, doctor. So moving to the second patient, it's Dr. Vinayak Hirinath. This is an EVO India study, ACP India chapter initiative. So may I have the CV of Dr. Vinayak?
Dr. Vinayak Hirinath is a practicing physician from Canada, and he has recently been elected as council member of the ACP India chapter also. So Dr. Vinayak Hirinath is going to present this very important study, that is an EVO India study. And this study is an initiative of ACP India chapter. Dr. Vinayak, please.
First of all, I would love to thank ACP India for providing us this platform and our governor. We are able to have rich data of research studies which are happening in India. Today, one such of study is Evo India study. So this is a real-world prospective observational study on the usage of evogliflozin in India, its effectiveness and side effect profile. So the principal investigator was Dr. Anuj Maheshwari sir himself. The study is funded by Ankam Lab. So why this study was conducted? The main focus of our study, the drug was evogliflozin, which is a DPP-4 inhibitor used in the treatment of type 2 diabetes. It's available in the India and marketed as a single or in a combination, that is with metformin. In the meta-analysis of Datta et al., they found that evogliflozin exhibited a high degree of non-inferiority and even in some cases the superiority compared to sitagliptin and linagliptin in terms of glycemic control among type 2 diabetes patients. And also the study suggested that it's been well tolerated, effective standalone treatment option for the type 2 diabetes treatment with the minimal side effects. However, there is a very scant data. Except the phase 3 trial in India, among the Indian population, we don't have much of data on this evogliflozin. So our study's main objective was first to see what kind of patients are this who are receiving evogliflozin. That is the patient profile, information on safety, treatment effectiveness, and also the mean change in 3 months of first HbA1c, fasting plasma glucose, and postprandial plasma glucose. Secondary objectives were body weight, LDL, and change in creatinine. And also we assessed the tolerability among the various patient cohorts, especially by age, gender, and presence of comorbidities. And to get an overview and detailed understanding on the landscape of evogliflozin usage in the management of type 2 DM. So the inclusion criteria was aged above 18 years, clinically diagnosed type 2 DM, being treated with evogliflozin monotherapy or in a combination therapy. The exclusion criteria were age less than 18 years, pregnant or lactating women, currently not being treated with evogliflozin, or those who have not been given their consent. So this was the study design, prospective observational multicentric study, which we started on 4th April 2023. Data was captured during the patient routine visit. Consecutive patients who were eligible were included in the study. The duration of study is 9 months. We have just completed around 3 months. So the number of sites, 40 sites across the India, as per the site evaluation criteria. So what we gathered was the baseline of 1377 patients. And we have a very minimal data for the first follow-up because the study started very recently with 198 patients in the first follow-up. We got the ethical clearance for this study. So what we our study answering? Basically, the profile of type 2 diabetes patients, who are these patients who are getting evogliflozin, and whether it is being prescribed as a monotherapy or in a combination therapy, or is this drug being switched from the other drug or being added to the present therapy. And we will be also monitoring the glycemic control, incidence of complements, and side effect profile. So first let's see who is evogliflozin being prescribed to.
So as I told that we had 1377 patients, we could not get the HbA1c value of almost 238 patients, so we excluded them. So we had the analysis of 1139 patients. And this is the demographic data what we have. You can see that the average age of patient whom the evogliptin is prescribed is 53.8 years and with 58.6% for males. Coming to BMI, that is good standpoint for our study that like 70% of patients are obese and 16% were overweight. And 3% had the grade 2 hypertension and 20% had grade 1 hypertension during the consultation. So physicians were confident in prescribing evogliptin even in the obesity individuals. So this is the social habits. I'm not going in detail because this is yet to be evolved. Coming to patient profile, you can see the average duration of diabetes was 6.23% and highest being more than 15 years. And talking about the complications, almost 77% of our patients did not report any complications, except like 16% patients reported the complication that major being the neuropathy. This is the comorbidities what our patients were having, that is 45.2% with hypertension, dyslipidemia with 27.1%, 11.6% hypothyroidism, 10.1% obesity, 2.7% kidney diseases, ischemic heart diseases 2.1% and heart diseases 1.2%. So looking at the average A1C, the average A1C was 8.3% and fasting glucose of 153, postprandial of 231. So the creatinine at an average level in the beginning of our study was 1.01 and the average LDL which were included in the study were 106. So let's understand the landscape of evogliptin usage in the management of type 2 diabetes, especially in Indian setup. So to answer the question, monotherapy or in combination, you can see 16% of the patients were prescribed evogliptin as a monotherapy, while 84% were in combination with other anti-diabetic medications. So that is accounts for 32% of dual therapy and 29% of triple therapy. So whether it was an addition or a replacement to the existing treatment, evogliptin is prescribed as an add-on therapy for 93% of our patients. So what was the major reason for adding evogliptin was uncontrolled glucose levels. And 22.5% felt that there was side effects, 16.5% felt that advanced drug for better outcome, and then drug resistance of 11.3%, improved adherence of 9.7%, reduced the number of drug dose by 7.2%, patients with obese category 3.3%, kidney issues with 2.4%, and liver issues with 0.8% and others. So basically 82% of patients were started on evogliptin because their sugars were not controlled. So 3 months follow-up. This is very scan data we have, that is only 198 patients. So what we found is the overall reduction in A1C was 0.42%. So it was more in males, like 0.52, compared to females, 0.31. And when we talk about the drop in A1C in age gender, the younger age had the greater reduction, and that kept on increasing when the age increased. Looking at monotherapy versus the combination therapy, what we found was overall 0.42, monotherapy of 0.5, and combination therapy 0.41. Looking at change in fasting sugars, postprandial sugars, weight, and creatinine. Fasting sugar also significantly dropped by 8 to 10 milligram per deciliter, postprandial by 10 to 15. There was no change in weight gain or weight loss. Creatinine value also remained normal or at the same level. It was not statistically significant increase. Looking at the safety profile, 94% had no complaints, never reported any complaint. Only one patient reported of tingling and numbness, which was attributed to his diabetes. Moving on to discussion of our study. So we all know that evogliptin is a selective, potent and reversible inhibitor of DPP4, extensively studied for its efficacy and safety, approved in South Korea, dosage 5 milligram per unit, which is being prescribed in India. So when we answer like are all DPP4 same, we have this like sitagliptin, teneligliptin and evogliptin having an extensive binding. You can see evogliptin which binds to S1, S2 and S2 extensive binding, making it more potent. The pharmacokinetics, I'm not going to deep into this as we all know aware about this. So about the study discussion, like DPP4 inhibitors have shown a substantial and clinically significant decrease in glycated hemoglobin without causing a weight gain and with no occurrence of hypoglycemia in individuals with type 2 diabetes. So even in the prior clinical trials where DPP4 inhibitors were used as a monotherapy for 24 weeks, they have been found that lower A1C levels by range of 5.5 to 0.8%. So even our study achieved in between of 0.42. So DPP4 inhibitors generally work by increasing incretin, that is GLP-1 and GIP levels in physiological range to improve the pancreatic beta cell function. So what are the noteworthy points about this evogliptin study? It demonstrated a high rate of selective DPP4 inhibition exceeding 80%, improved pharmacokinetic profile, which supports to be used in even the patients who are having issues with kidney because it is bypassing the renal metabolism. Furthermore, it is recommended to be superior effectiveness in reducing blood glucose levels when compared to other DPP4 in the same class. A study conducted at Park et al. In 2017 reported that evogliptin monotherapy resulted in a significant reduction in A1C 5.3%, while our study, which is showing at 0.42%. And a systemic review and meta-analysis conducted by Tang et al. In 2022 reported that evogliptin showed a mean difference in 0.062, reducing the A1C levels, and is no way inferior to sitagliptin or linagliptin. ACP, that is Evolution India study, found that 5 milligram a dose of evogliptin had a greater significantly impact on A1C compared to 100 milligram of sitagliptin with lesser amount of side effects. And what about the body weight? Because nowadays it's more of metabolic what we are concerned when treating diabetes. So as we all are aware of DPP4 inhibitor usage not causing the weight gain, the study conducted by Zerko et al. In 2019 demonstrated a 1 kg reduction in body weight when treated with evogliptin 5 milligram and even in the higher range of 10 milligram monotherapy. After 24 weeks of treatment, mean body weight change from baseline in evogliptin group was 0.414 kg. So in our study, even though we are not revealing because we have a very scant data, but there is some amount of weight loss, but not a single amount of weight gain. Minimum side effects. Yes, evogliptin possesses the most advanced DPP4 inhibition, which can exert an hypoglycemic effect with good selectivity, high potency, and fewer adverse reactions. Sacco et al. And Hang et al. In findings indicated 100 milligram of sitagliptin resulted in fewer side effects when compared to 5 milligram of evogliptin. Ashwini et al., Akim et al. And Detta et al. Demonstrated a reduced adverse event outcome for evogliptin group and no difference between the evogliptin group as compared to the other DPP4 class. About the creatinine levels, a systemic review which meta-analysis by Ray et al. In 2019 reported that DPP4 reduces the UACR and eGFR levels and have a renoprotective effect. So evogliptin reported as similar in our studies which were conducted by Park et al. And et al. According to Kim et al., evogliptin monotherapy reduced the UACR by 0.424% and eGFR by 0.8% from the baseline. So even in our study, there was a significant decrease in creatinine levels. How about combination therapy? When used in combination therapy with metformin, other drugs, evogliptin reduced the A1C of almost 8.8 and fasting from 159 to baseline 128 and to prostrandian 238 to 188. RCT conducted by Hong et al. Patients with HbA1c levels 6.5 to 11%, who were receiving the stable dose of metformin, showed a reduction of 0.59% reduction in A1c and it was well tolerated. So to conclude our study, the use of evogliptin led to a significant reduction in A1C levels and was well tolerated. among all type 2 diabetes patients, especially in our Indian sector. Therefore, evogliptin can be regarded as an effective and well-tolerated option, whether used in monotherapy or in combination therapy for the treatment of type 2 diabetes in India. We do have some limitations for our study. Since it's an ongoing study, we are planning to conclude it by December so that we get a chance to publish this in ADA in coming year. And at the time of conducting this analysis, there was no available data for the 6 months follow-up. Thank you.
Thank you very much, Dr. So that was a very interesting, I think, real-world study looking into the prescribing pattern of evogliptin, that is the entire prescribing pattern. So what important thing which comes to my mind is that in your patients, in whatever data it's not completed, but in whatever data, how much, at what stage was evogliptin started? Was it the first drug or the second drug or the third drug? Because that also becomes very interesting when we look into what are the recommendations given by the ADA and other associations. So in an Indian scenario, what is the physician's prescribing pattern and at what stage they added it before inhibitor? That would be interesting to know.
Yeah, we have a doctor, but we are not allowed to comment because since it is very earlier part of our study, so whatever we are going to comment on that might change in the larger part when we get the data of the second patient. But like as of an average, what we saw was like average A1C of 8.8 to 8.6%. It was started initially. Second or the third.
Communication with Vinayak for a study. So this study on this molecule, PP4 molecule. So it was started in 2015 in South Korea, but in India it was started in 2019. After that, there are studies done. This study was also different that we have highlighted in those studies. So my first question is like, what's new in your study? If you compare with the already existing study with this molecule, what's new in this study? And second question is like, in total the DPP4 class drugs, this drug is like in some studies showing little bit benefits, but more adverse effects. In some like data is not like if you do meta-analysis then you can confirm it. But like why one should prefer this DPP4 molecule, not this?
So like very simple. First, if you see, there is very scant data on this. This is a very new molecule for us, and whatever the studies or data are there, those were the phase 3 trials. And apart from that, very small number, 180, 120. So we plan to see, not compare with any other drug, just to understand how it is doing in India, what kind of patients are receiving this drug, and how it's affecting them, and how physicians are competent enough to use this drug. So we were just understanding about this drug. And meanwhile, to add the knowledge gap which was existing, it's been proven well-established drug, so why we not have our own data for this drug?
So the one important point which you want to highlight is the number of samples. That is bigger in your study?
Yes, sir. Our number of samples is one thing. Second thing, we also want to see, since the adherence part also improves with this drug, since it is given as a single dosage, not with other like twice daily or something of that. And renal protection is there, and equivalent to the amount of A1C reduction compared to the other lipids.
Adherence was more with this drug.
Yeah, adherence was more.
What was the reason which can?
So like we can't definitely come to that point, but we can say that like since it is used as a single 5 milligram, there is a mentality which in Indians, if I say that I'm giving 5 milligrams for your controlling type 2 diabetes, patient is also happy if he is taking the less drug. When I say if I'm increasing it to 100 milligrams, it means
You want to highlight pill size? Pill size because of the small pill size that has or it is because of lesser side effects.
Lesser side effect is one, greater reduction in A1C, and also the dosage of the drug to be given.
Thank you.
Really, I would like to comment that this study has been kept on the platform of ACP and contributor also. So that's why I have an experience of that study. Actually, idea was behind starting this. No electric was very robust in India. Whatever we are implementing that, and Indian, what is said for the other elections also that is for Indian, where I am doing that either just experience or what do they say, they have done in the Indian population living in the US or the Western country. On the basis of what they say, it is realistic this much of the university in India. So, idea behind was that we should have a robust military data for Indian population than in India, and actually this study also been done by the so that this has been created this idea, and we have tried to find out the investigators across the country. And people have supported this idea, they have given their attention support also, so that we could be able to collect the real world data. So this was there was no idea behind comparing it with the other. And he didn't like this saying that because one time we are doing the application and small bill 5 milligram and once in a day and working the same function what any other molecule in 100 milligram or twice a day. So obviously patient prefers that less number of medication, less dosage. And there is the mentality of the patient also. If you give the 5 milligram medicine and you give the 500 milligram of medicine, then they are always scared of 500 milligram. Even it is metformin, still they are having some fear that, oh, doctor has increased my dose 500 from 5. So 100 times dose has been. Some patient comes, he must be coming to you also, they say, but doctor, I was taking 5 milligram of medicine, but another doctor has increased 500 milligram. That's why I was scared. So these kinds of mentality always keeps on going. And because of what we get, although it has not completed, we are still in the implement of the follow-up. The first, no, that is also a beginning. Even those modifications are also not required like in writing those modifications is also not required. Because of all these petitions are also more comfortable, they don't have to be. So they have been and somewhere we get
Since this drug in renal patients, one more study has also come, a very small number, 20 to 25 patients. They did a study in ICU acute renal failure patients, and they found that no need of reduction of dose.
So evogliflozin was a very, promising drug of choice, especially in the previous time. But now that the drug rates and the generics have come up, because other competitors at much cheaper rates, now it has become somewhat expensive. Otherwise, it has a very good profile. Just one small thing I would like you to consider that. Please consider at what number of medication was started. That would be really interesting data. First, second, or third, that would be very interesting. And I hope you see prolongation.
We are monitoring.
I think any other questions from the house?
Yeah, like if you take a meta-analysis of all the DPP4 inhibitors, it's almost like 0.5 to 0.8%, and we had like 0.4 to 0.6%. Monotherapy had 0.4%, and combination therapy had 0.5%.
All right. So, how does it make it? What is new in it?
So, new in the sense, as we talked just now, lesser side effects. You need not monitor much to your patient.
Most of the DPP4 they do not have.
At least if the patient is ending in some renal issues, you need to alter the dose or monitor the drug.
None of the DPP4 have shown any damage to the kidney, or even you continue with the 100 milligram dose of sitagliptin. They do have it, but there are many studies available. They say that there is no damage to the kidney.
Actually, it is not a comparative study. It is for the first time they are trying to generate data on immune. So it is not compared with any other.
No, I was just trying to look at that is what is new for us.
Thank you, Dr. Vinayak. Thank you.
Thank you, Dr. Vinayak Hiraman. Now next we go on to the third interesting research case here, Dr. Dinesh Kumar. He is going to speak on ACP India subclinical hypothyroidism study. This is again a very interesting study done by under the ACP initiative. Dr. Dinesh Kumar is a well-renowned physician from Lucknow, and he has contributed significantly to the study. Luckily, I also am one of the co-PIs of the study. So, I invite Dr. Dinesh Kumar to start this session.
Thank you, Chairpersons. Thank you, ACP, for giving me this opportunity to speak on this very interesting trial. And thank you, audience, for being here at this hour. The study was based on looking into all the type 2 diabetic patients coming to our clinic, and what we are trying to look into it is the prevalence of subclinical hypertension. So this is a very interesting thing because many studies have been done regarding the correlation of diabetes with hypothyroidism. But here we are trying to specify two things. One is it should be type 2 diabetes. Number two, we are looking for subclinical hypothyroidism. So the platform we used was Medipa. They were very helpful throughout the study as far as the electronic platform is concerned and generation of data and compiling of data. These were all the contributors throughout India. So what are we trying to answer in this study? What is the prevalence of undiagnosed subclinical hypothyroidism in persons living with type 2 diabetes? What is the prevalence as far as age and gender is concerned? What is the association as far as glycemic measurement, glycemic control is concerned? What were the signs and symptoms different in persons with subclinical hypothyroidism and with normal thyroid functions? Diabetes and thyroid disorders are the two most common endocrine diseases, as we all know. Uncontrolled diabetes mellitus may disturb thyroid metabolism by disturbing the levels of thyroid hormones in the plasma. We all have been studying this for the last many years. Hypothyroidism refers to common pathological condition of hormone deficiency, and if left untreated, it can cause serious problems. What do we know? How do we diagnose subclinical hypothyroidism? TSH more than 4.5 with a normal T4 or normal T4. Poorly managed diabetes leads to insulin resistance and hyperinsulinemia, which cause thyroid tissue proliferation, thyroid nodule formation, and Boyd disease. They also disturb the hypothalamic pituitary thyroid axis. The British Thyroid Association, probably because of this, has recommended all new type 2 diabetic persons should be screened for thyroid in the very first place. American Thyroid Association does not recommend so, but what they recommend is all persons more than 35 years should be screened for thyroid. Current Indian guidelines don't have any such recommendations as far as correlation of diabetes and thyroid is concerned. So no guidelines regarding continuous screening or regular screening of diabetic patients for thyroid disease is concerned. Therefore, we thought that it is imperative that we try to generate some data and to prove that yes, we require continuous monitoring of thyroid hormones, especially the TSH and T4, in all our diabetic patients, the type 2 diabetic patients. The primary objective was to determine the prevalence of subclinical hypothyroidism among Indian patients with type 2 diabetes mellitus, and the secondary to assess the association of subclinical hypothyroidism in type 2 diabetes persons as regards gender and age. And third, the most important what we're looking for, what was the glycemic parameter, what was the glycemic control in all these persons with subclinical hypothyroidism and diabetes. Study design, it was a multi-centric descriptive cross-sectional study. The study is still going on. Till date, the sample size we have got is around 1800 patients. The data was collected from 3rd March to 31st August. The definition, as I told you, TSH more than 4.5, T4 or FT4 normal. Inclusion criteria, all Indian adult persons with type 2 diabetes over the age of 18 years. Those who give consent and exclusion criteria, especially the ones who are known case of hypothyroidism, we excluded them. We excluded the patients who had any other reason for diabetes, type 1, LEDA, MODI, whatever. Patients who are taking drugs which could hamper our thyroid levels, persons taking amiodarone, lithium, persons who are having any acute illness or maybe having thyroiditis, and pregnant and lactating females are also excluded. This approval was taken as per schedule, and these are the patient profile at the baseline. I can say not the baseline, but what we got initially before we actually analyzed the data. Mainly, it was the male preponderance overall study population. If you say most of the persons, 50, it was if we calculate from 54 years age, it was like 50% patients were less than 54 and 50% were more than 54 years of age. BMI, most were overweight or obese, 80% of them, and BP was probably equally divided among all. Most of them were having normal blood pressure. As far as duration of diabetes is concerned, the average duration was 6.6 years, and complications which we found was only 20% of cases, probably because we were at a physician level this study was done, so probably we are not getting too many complicated cases at our center. Glycemic control, most of the patients were having an average, the average glycemia was around 8, hemoglobin of 8%. Fasting, most of them were on the higher side, 150, and primary blood sugar was also on the higher side, around 119. So what we got once we analyzed, so what we were looking for, we were looking for a thyroid normal. This is normal thyroid. TSH 559 were normal, and out of them, above normal, sorry, 559 above normal, 31%. Out of them, how many had normal T4? So that came out to be 20%. So the prevalence of subclinical hypothyroidism in our study was 20%. So we're not going into the other details of what we got because the primary objective was this. Gender bias was not there. Both male and female were equally affected by subclinical hypothyroidism. No definite preponderance towards age, both younger and extreme elderly also had similar kind of prevalence of subclinical hypothyroidism. BMI, very low weight, that's underweight, had high prevalence. Very overweight, obese patients also had high prevalence. BP, not much in it, all had similar kind of prevalence, so BP we couldn't get anything out of it. This is very important. The most important finding that we are looking for, the glycemic control, was there an association of subclinical hypothyroidism and glycemic control, but finally we couldn't get any definite correlation. The persons, in fact, who had normal thyroid were having higher A1C as compared to those who were having subclinical hypothyroidism. Again, in fasting and blood sugar, there was no difference. Both groups of normal thyroid and hypothyroid, subclinical hypothyroid had similar kind of fasting blood sugar, similar kind of postnatal blood sugar. Symptoms, in fact, were more with the subclinical hypothyroid. Be it fatigue, be it constipation, weight gain, dry skin. So most of the symptoms were more common in the group of subclinical hypothyroidism as compared to the normal thyroid. So to conclude, the prevalence of undiagnosed subclinical hypothyroidism was 20% in our study. Prevalence of undiagnosed subclinical hypothyroidism had no difference whatsoever as far as gender and age is concerned. There was no association of glycemic control with our thyroid status. But patients with subclinical hypothyroidism were more symptomatic as compared to those having normal thyroid. Discussion. Well, prevalence was equivalent to many other studies done in the past. What I went through, a few studies, they had prevalence from 13% to 46%, but most of them were from 13% to let us say 26%. The one study which talked of 40%, 43% took the upper limit of normal thyroid as 3.5. That's why you probably got more number of patients as subclinical hypothyroidism. The elevated occurrence of subclinical hypothyroidism in individuals with type 2 diabetes may be attributed to autoimmune, as we all know. Given the heightened prevalence of subclinical hypothyroidism, it is advisable to assess thyroid functions in all our patients of type 2 diabetes. In present study, the prevalence was 20.6% in females and males was almost same as 18.8. And it has to be seen that these all findings were probably similar to the findings that we were seeing in the previous studies done in the past. Again, as expected, most of the patients were either overweight, 24.4%, or obese, 22.9%. Hypothyroid was also seen in underweight patients, probably because of malnutrition can also lead to slightly raised TSH. And several studies have shown that weight gain leads to hypothyroidism. Blood pressure, as I told you, there was nothing in it, we couldn't get much out of it. Almost all levels of blood pressure had similar kind of prevalence of subclinical hypothyroidism. To our surprise, glycemic parameter we couldn't correlate in our current study. In fact, the A1C with subclinical hypothyroidism was lower as compared to those who had normal or those who were euthyroid. So that was a surprise for us. The findings were contradictory to many previous studies done by Sharma et al. And Handler et al., which have shown that higher glycemic prevalence with subclinical hypothyroidism. Thakur et al. Has also reported type 2 diabetes having a patient with subclinical hypothyroidism with higher mean and higher A1C. So there are few studies, more studies which have shown glycemic correlation, but there are few studies which have shown that they couldn't get any correlation, just like we couldn't get any correlation with glycemic parameter. So the findings of this study indicate notably higher prevalence of thyroid disease in individuals with diabetes. Research revealed that subclinical hypothyroidism was nearly twice as prevalent in the population with type 2 diabetes compared to the general population. Moreover, individuals who had both type 2 diabetes and subclinical hypothyroidism are at greater risk of experiencing diabetes complications, though we couldn't prove it as such. We advise, our guidelines also that we include having thyroid measurement in all our type 2 diabetic patients. So in light of this evidence, it is advisable for national guidelines to incorporate recommendations for the screening of thyroid function in individuals with type 2 diabetes. Thank you so much.
Thank you, Dr. Dinesh. Very nicely conducted study. I would like to ask one thing, since we have documented two things. One is that prevalence of subclinical hypothyroidism is almost 20%. And you also said that these patients, they were having more symptoms than those patients who have normal thyroid functions. So what was your clinical approach once you diagnosed these patients with subclinical hypothyroidism? How did you follow them? Did you prescribe treatment to them? What was the next course of action?
Actually, subclinical hypothyroidism, especially two categories we talk of. Elderly is not recommended to start the treatment at the outset. And in youngsters, depending on the symptoms, we start.
I totally agree with you. But since this is a subset of patients with diabetes, and people with diabetes, they reported higher symptoms. So, do we do something to counter those higher symptoms in these patients? So, this is my clinical question.
So that's what I said. If the patient is having symptoms which we can correlate with hypothyroidism, and we are getting to go diagnosing subclinical hypothyroidism, we can obviously start hypothyroidism and keep a follow-up. Anti-TPO antibody is one test which we can do in these patients to confirm whether we have to initiate hypothyroidism or not. But probably anti-TPO antibody, though we got it done, it was not actually mentioned in this study.
Congratulations for a very good study, the way you presented. So I have 2-3 points which I want to some queries are there. The sample number, the sample size is 1,808. So how you calculated that? What were the things which were there in your mind to come to that figure, 1,808?
It's an ongoing study. It's not the final figure that we have reached. It's the study which we have been doing for last 6 months.
So basically, the sample size is calculated as per, it was calculated as per the, what do you say, occurrence, prevalence of subclinical hypothyroidism and diabetes in the previous studies. Accordingly, the data is, then a lot of them were taken into consideration. There was one main basic index study, which was taken, index paper, which was taken into consideration. And then what is done is that when you enroll the patients, then there are some issues. For example, in some patients, TP is not measured, in some patients, T4 is not measured. So accordingly, they were removed, and the final size that we got was 1,880. So it was not contemplated as that size, but it was as per the after exclusion of the other patients who were probably not in our product.
Second, in a patient in which you are living in subclinical hypothyroidism, we have the differential also, like a central hypothyroidism. So central hypothyroidism can have somewhat little bit pictures similar to subclinical hypothyroidism.
That's why we went that. We had two patients who had high TSH, slightly higher TSH, and T4 also slightly higher. We had 10 odd patients. But we didn't take into the account because we were focusing on subclinical hypothyroidism. We excluded the whole thing except that part.
Okay, so the third point which I want to highlight is the BMI. So we know when the BMI increases, TSH also increases. So in your study also that part has been highlighted. So how much what was the correlation of the BMI with the TSH which you have found in your study?
Most of the patients, more than 80% are either obese or overweight.
So what I want to highlight is we do not have any normative data of TSH for our Indian population. So what we think as a subclinical, sometimes for that population that can be a normal also. So it's very a dicey figure which we say. We believe whatever is the traditional way of teaching, but we do not have a normative data.
See, that's why whenever we find ourselves in this dilemma, we take the help of antibodies. So if we have antibodies present, then probably we can think that this person probably is going to land up into hypothyroidism and hypothyroidism in the near future.
And one peculiar finding which I think which you have highlighted also, the subset of the patient in which diabetes was uncontrolled, the subclinical hypothyroidism was very less. So
see, that was a surprising finding for us also. And we don't have any good explanation for that. So, but one explanation I thought I've been thinking for last 2-3 days. What can be the reason? See, whatever studies I have been going through for last few weeks, let us say, most of the studies are taking the age limit as 40 plus. Probably this is the only study which is talking about a younger and newer, probably drug diabetes naive patients. So they have very high A1C at the very outset. Maybe that is the reason that we had more naive patients, younger patients who were presented to us with high A1C, and we have included them into the data, and that's why the A1C got deranged in that.
Because if we understand the thyroid hormone relation with the blood glucose, when there is a hypothyroidism, the diabetes deteriorations will be more. When hypothyroidism is there, the risk of hypoglycemia will be more.
So it's very complex. It's not all that simple. Hypothyroidism affects at many levels.
That is, yes, what Dr. Abhishek is saying is a very different thing. Like when we see hyperthyroidism, definitely glucose intolerance is there. And when we talk about hypoglycemia, it's usually correlated with a lower glycemic level. But that is not the case. Actually, when we say this study, mainly we say what was done was we looked into the cases of undiagnosed subclinical hypothyroidism. So we are not seeing the prevalence of thyroid disorders in type 2 diabetes. Mind you, the prevalence of thyroid disorders would be much higher, probably up to the tune of probably 25 to 30% as per our what we got the results, because we excluded the patients who were known cases of hypothyroidism. So patients who do not have any percent of them were found to be having subclinical hypothyroidism. And there were some patients who came with overt hypothyroidism also, that is not included here, because, and even some patients with overt hyperthyroidism, that is also not included here, because here we are focusing only on subclinical hypothyroidism. So that is very important, that many patients come to us may not have any symptomatology suggestive of hypothyroidism, but we should probably try to evaluate at least once and probably include in the guidelines. That is what your suggestion would be. So I think with that, any other questions? Any questions from the house? So with that, I will conclude a very good presentation by all the three speakers. And Dr. Anuj Maheshwari is busy with another session. So there is an announcement that all the three speakers made very good presentations, and very good presentation was there. They were the top contributors in these studies. So they will be felicitated tomorrow in the function, which is going to be there in the evening. And they'll be felicitated over it. Congratulations, folks. That will conclude our session. Thank you for the lovely session. I would now like to request so could you please, I don't know the name, I didn't have time to ask. Ma'am, could you please come up and felicitate our speaker? We can call upon the stage the three speakers. Dr. Cheramat, Dr. Aslam, and Dr. Dinesh.
Side, please.
Session for the next topic is heart matters. For that, I would like to welcome our chairperson, Dr. Santosh Shwai, and Dr. Mihar Gadais. Welcome our chairperson to the dais. I have to say that to welcome our speaker for the next.
So here is an interesting session, back to back. In the first, we invite Dr. Akash Singh. Will be dealing with the clinical evaluation of cardiac markers with the invention of AI, we don't think that still the clinical examination is obsolete. So please prove it.
I thank the organizers of ACP India for giving me this opportunity to speak. I will be talking on a topic which is getting more and more obsolete, that is clinical evaluation of cardiac murmurs. A heart murmur is defined as a prolonged series of audible signals or vibrations of varying intensity, frequency, configuration, and duration, generally detectable with the aid of stethoscope. Sometimes the murmur is loud enough to be heard without the aid of stethoscope, or may be palpable as a thrill. Turbulence is the primary factor behind the genesis of murmurs. Now, the determinants of turbulence are velocity of blood flow, it is the primary factor. When blood moves from a small chamber to larger one, or when the velocity of the blood is too much and the orifice is narrow. This may result with physiological high velocity flow or from narrowing of orifice. If there is a low kinetic viscosity of blood, which is seen in severe anemic states of flow, then also murmur is produced. Now, turbulence is caused by valvular disease, stenosis, or incompetence, septal defects, or vascular defects. Now, if you see the heart, we have base of the heart and the apex of the heart, and the murmurs basically depending on their genesis, they radiate from base to apex or swell to forth. So, if you see the location murmurs, this is the aortic area, that is the second intercostal space. Pulmonary left second intercostal space. In the at the sternal edge, the earth area where S1, S2 and the murmur of HOCM is very high, at the third intercostal space left side, and the tricuspid area, the left fourth intercostal space, and the vital area which is the fifth intercostal space, but in the mid clavicle line. The timing is also important, whether it is systolic, diastolic. Heart sounds can be distinguished by 7 days formation of carotid pulse. So we can differentiate, and murmurs are generally longer. Now the shape of the murmur is also important. Crescendo, decrescendo, crescendo, decrescendo, or plateau-like murmurs. Now if you see, some murmurs radiate, and the intensity of the murmur is reflected by its radiation and direction of blood flow. Now intensity is given on a 6-point scale. Grade 1 is faint murmur which can be heard in a quiet room by an expert. Grade 2 can be heard in a quiet room. Grade 3 is moderate in number, grade 4 is loud, grade 5 is heard without stethoscope, and partly of the test of the chest in grade C is no stethoscope is needed. Now, thrills are associated with murmurs of grade 4 to 6. Systolic murmurs of grade 3 to 6 are generally hemodynamic significant, and diastolic murmurs are generally all organic in nature, whatever be their intensity. Now, pitch of the murmur is also defined. It is high pitch, which is better appreciated with the diaphragm stethoscope, like murmur of aortic stenosis, and low pitch, which is better associated with the bell of the stethoscope, like the murmur of mitral stenosis. The quality blowing, like murmur of stenotic harsh, and rumbling or musical, like the murmur of MS and TS. Others are the variation with respiration, variation with the position of the patient, and variation in the special maneuvers. So the murmur of aortic stenosis will be better heard by leaning forward, because the aortic wall is close to the chest. Lean forward, it comes still more closer to the chest. Likewise, the murmur of mitral stenosis, if you heard it here in the left atrial position, is better heard because the wall comes closer to chest in this manner. Now, inspiratory murmurs increase with inspiration because the blood flow increases to the right side of the heart. So the right side murmurs increase with expiration, left side murmurs increase with expiration. Now, what are the maneuvers we make to make murmurs louder or softer? First thing that we increase the preload. Now, how we increase the preload? By sweating or like this. So it causes more blood in the cavities of the heart to increase in the murmurs. However, the murmur of HOCM will decrease because as the cavity expands, the dynamic obstruction decreases. And the murmur of MVP also decreases because MVP there is it is generally mid and late systolic murmur, and the mitral valve, which is rhizometal basically, will prolapse late the LV dimension support, and that leads to late ejection and late onset of murmur. Valsalva is to decrease the preload And because also what happens, the RV feeling decreases, and that decreases the murmurs in general. However, the murmur of HOCM and MVP decrease because in HOCM less blood in the ventricles, more obstruction and harshen the murmur, and in MVP the aortic wall will collapse earlier, basically into a longer murmur. Now you can have maneuvers to increase the afterload and there is the murmur which increases the afterload, and with the increase of afterload, the regurgitant murmurs will increase. However, the murmur of HOCM again will become softer because the LV cavity dilates, increase in afterload, and MVP basically also gets shortened because of collapse to longer leg. There are maneuvers, drugs like amyl nitrate which decrease the afterload, and they will make the murmurs of HOCM louder and the murmur of MVP also longer, basically, and other murmurs will decrease. So these are the specific maneuvers to assess the murmurs and to quantify them and to recognize them. Now we can have systolic murmurs, diastolic murmurs, or continuous murmurs. We can have early systolic, mid systolic, late diastolic, or fast systolic, and likewise the diastolic murmurs also can be quantified. So you can see this is the past systolic murmur, this is the crescendo, decrescendo, mid systolic murmur, this is the early systolic murmur, this is the late systolic murmur, and you can quantify them with the S1 and S2. So systolic murmurs can be produced by incompetence of heavy walls, stenotic of similar walls, murmurs due to anemia, septal defects, coordination of aorta. Now, early systolic murmurs are generally murmurs which are regurgitant and they are high pitched, decrescendo in complication, begin with S1 and end well before S2, usually at before mid systole, or the acute severe MR, acute TR with normal RV pressures, small VSD or non-diastolic VSD with pulmonary hypertension. Because of the increased RV pressure or increased pulmonary hypertension, these murmurs get rated early and they are the early systolic murmurs. Acute severe MR, radiation murmur to the base of the heart, that is the left second intercostal space, as the regurgitant jet is eccentric and directed anteriorly, often associated with expiratory S2 split and loud S4. S4 is late diastolic filling of the heart, is S4, and early diastolic filling of the heart is S3. Acute TR is soft, medium pitched, and augments on inspiration. It is associated with right-sided S4. So the voice is not correct. Now the ejection systolic, these numbers are high to medium pitched, descending to decrescent complication, often defined as diamond shaped numbers. Systolic ejection in nature that begins after S1 and ends well before S2. The intensity of the number closely parallels changes in cardiac output. The causes are aortic stenosis, HOCM, stenosis. Function may be due to dilatation of the aortic root, due to dilatation of the pulmonary trunk, due to extended flow into the aorta, or due to extended flow in the pulmonary artery. Innocent mid systolic murmurs due to flow across the normal ventricular outflow tract. Now, aortic stenosis, generally the significant aortic stenosis in the aortic wall area decreases to 70% of the normal. It's loud, harsh, medium pitch, best at the left and second intercostal, right intercostal space, in sitting position, accompanied by systolic thrill, better heard on leaning forward, more severe the condition, later is the peaking and prolonged duration of movement there. Due to high velocity jet within the aortic groove, the murmur conducts to the leg along with carotids. Now, in elderly patients, you can have a double murmur, which is called galvanic phenomena, where there will be noisy murmur of the aortic stenosis, but because of the high frequency musical murmur of at apex also may be heard because of high frequency vibrations of the fibrocalcific aortic cusp. Now, we can also have a murmur of bicuspid wall, where you can have ejection fraction followed by crescendo murmur, and the intensity of murmur as well as the ejection click basically depends on the pliability of the bicuspid wall. It is not the severity but the pliability of the wall which is important. Unfortunately, audio is not playing. Now, the murmur of HOCM you can differentiate because it is best heard in the left second, third intercostal space. It also basically heard well at the base of the heart basically. And here you see the differentiating point is, as we already seen, that it does not conduct to the carotids basically, unlike the aortic stenosis. And here basically the maneuvers which already we have described will decrease or increase the intensity of murmur, and by that we can differentiate it from the murmur of aortic stenosis. So these are the maneuvers which already we have discussed. I will not again go into the details of these maneuvers. Now, pulmonary stenosis, best third in the pulmonary area, that is the left, second, third intercostal space, accentuates during inspiration and may be conducted to the left supraglottal and left side of the neck. Begins with pulmonary systolic ejection sound. In severe pulmonary stenosis, the ejection sound fuses with S1 and S4 is audible. P2 becomes soft and S2 splits widens with the increasing severity of stenosis because the P2 component comes later. Associated with prominent areas, the signs of right side heart failure are prominent. So you can have the jugular veins which are seen left pedestal here, and right side S4 may be audible. The past systolic murmur, the causes are chronic MR, chronic TR, and restrictive VSD. The classical murmur of chronic MR is high pitch blowing, plateau-like configuration with grade 3 to 4 to 6 by intensity, with no or minimal variation in intensity with respiration or changes in cardiac cycle arrhythmias. Murmur is left west third with apex can radiate. If there is an anterior mitral leaflet prolapse, then the radiation is there to left axilla, angle of left scapula, and the vertebral region. If the prolapse is because of the posterior mitral leaflet, then it radiates to the left sternal edge and the base of the heart. The severity is the louder the murmur, severe is the degree of regurgitation, along with systolic apical thrill, presence of LVS3 because of early diastolic filling, mid diastolic floor upper is C. Now this murmur depends on the LV function. If the LV function is good, you will have a good intensity of murmur. If the LV function is poor, intensity of murmur will decrease, and with fading LV, the murmur will go on decreasing. Now, past systolic murmur, that is TR, tricuspid elevation, holosystolic, when there is substantial elevation of RV systolic pressure, secondary to pulmonary hypertension or pulmonary stenosis. So, the more the pulmonary hypertension, the more the pulmonary stenosis, the harsher is the murmur and the longer is the murmur of tricuspid regurgitation. It is soft, high pitch, going in quantity, best third and the lower left sternal border with no selective radiation, increases in intensity with inspiration, which is called the Carvalho sign, but this augmentation is absent when there is organic TR or severe RV failure. In organic TR, the murmur is non-pulse systolic, lower in frequency, and RV systolic pressure is normal. Past systolic murmur, generally the murmur of ventricular septal defect is past systolic. The murmur is medium pitched, harsh in character, 4 by 6 grade, in intensity and associated with thrill. It is best third in the left sternal border, third to fifth intercostal space during expiration with no selective transmission. Late systolic murmur, the murmur of mitral wall prolapse, because the mitral wall elevation builds up and that leads to prolapse of the vixometer mitral wall. So is an ejection click basically and followed by murmur. So this murmur is generally late systolic murmur, and this murmur is high pitch, sometimes has a musical quality and is best heard by the apex. Frequently it's going to be single or multiple non-ejection clicks. Now coming to the cardiac murmur, they are present throughout the systole and dystole, and sometimes they are machinery-like murmur which are seen basically, and these are because of several reasons, especially because of hyperdynamic circulation with conditions like hyperthyroidism, vibration from hemangioma, hepatoma, severe anemia, all of cervical venous, all of these leading to rapid perfusion causing this continuous murmur. It may be because of localized arterial obstruction like coarctation of aorta or air pollution, stenosis, other major ulcers. It may be because of high to low pressure shunts, bidirectional shunts like systemic artery to pulmonary artery shunts. It may be because of anomalous left pulmonary artery pulmonary evolution. So several conditions which can lead to these murmurs. This is due to high to low pressure shunts which improve. Already we have seen all of these conditions which cause these murmurs. So the most common murmur is patent rectus arterius murmur, also called Gibson's murmur, and it is enough machinery precursor murmur peaking at S2, combination of high and low frequency vibrations and associated with thrill in left infraclavicular and pulmonary areas during expiration. Isometric hand grip will augment the murmur, and valsalva murmur will decrease the murmur. Now the conditions where PTA number will not be continuous, if there is a very small PTA which acts like a ball like the vacuum is not there, and if there is increasing pulmonary hypertension, which obliterates the diastolic component, then the number will not be there. There are several other causes of continuous murmurs like rupture of sinus. In rupture of sinus, the murmur is usually continuous when the rupture occurs in RV, RA or LA, but it is early diastolic if the rupture occurs in heavy because of higher patients. Other conditions are total enormous pulmonary venous drainage, portosystemic shunts, which are very commonly seen in cirrhosis and liver. Venous pump is another important condition where increased velocity of blood gives rise to continuous bleeding of the neck veins, which is known as cervical venous pump. And the thing here is that if you apply pressure on the internal jugular vein, or if you ask the patient to flex the neck towards the side of the venous pump will get obliterated. So there is very important point in this venous pump. Physiological causes are healthy children, young adults, status in pregnancy. Pathological causes are hyperkinetic circulation, increased AV fistula and moving of the skull, compression of jugular vein by the fascia or bony structures in the neck. Now, memory shuffle is another condition we see in 10 to 15% of the pregnant women during the second and third trimester. Heart better over the breast tissue because of the increased circulation in this tissue. The other reasons of continuous murmur due to localized arterial obstruction are localized systemic pulmonary arteries like the coarctation of aorta. The other ones like carotid stenosis, femoral artery stenosis, and renal artery stenosis can also can lead continuous murmurs. Coming to the last part of the work, which is diastolic murmurs, aortic regurgitation is a very important cause of diastolic murmurs. D syndrome, early diastolic murmur, heard loudest at the left sternum edge, sometimes heard loudest in the aortic area, and collapse pulse is pathognomic of this condition. There is a displaced hyperdynamic apex speed. Austin murmur is when there is a severe aortic regurgitation and the regurgitant jet mixes with the flow coming from the left atrium. So there are two jets which are merging, that is the flow from the left atrium, merging into regurgitant aortic regurgitation. Murmur, and this is a low pitch doubling from mid diastolic murmur, best parallel pulse. The typical features of mitral stenosis, low pitch doubling mid diastolic murmur with an opening click, but in the mid diastole, the mitral opens. Loudest about the apex, left atrial depressive position or aspiration. Other clinical features of mitral stenosis include low volume pulse, it may be irregular because a lot of these are associated with atrial fibrillation because of LA dilatation. Loud first start sound with tapping apex speed, the malar flush also to be seen. Now, pulmonary irrigation is a rare condition using asymptomatic typical features of PR include early DK syndrome murmur, heard loudest to the left sternal edge, loudest during inspiration, usually due to pulmonary hypertension known as Gram-Stein murmur when associated with mitral stenosis. Tricuspid stenosis, soft diastolic murmur, heard loudest to the left, the third, fourth intercostal space, left side. Typical features include mid diastolic murmur, loudest third to fourth intercostal space, loudest during inspiration. Other clinical features may include raised AVT, giant AVT, and ascites. So this is the schematic is the representation of all the murmurs. So I think we have covered majority of the significant murmurs, and I will end my session. Thank you very much.
Thank you, Dr. Singh, for the extensive elaborative discussion.
this formula. And it changes because it dislodges. Every time you activate the round, you find it change it per day. So, same person should examine it in the equal time. It is the error before the equal.
That is the way you build up order.
In iotic stenosis, it is my thought to demonstrate to my students that it can be hard for the carotid, for the mastoid, for the T2 spine, and also the original process. Okay, it's so nicely conducted, the application is normal. That it can be demonstrated to the other students. I hope you might have me. So it can be hard over the scalp, from forehead. It's so well conducted. We'll go to the bone, clavicular level. Thank you.
A very good afternoon to all of you. We welcome all the delegates of the holy city of Bhubaneswar. And next speaker is Dr. Smita Bhatt, and she is going to speak about life-threatening findings in ECG in OPD setting. It's a very common topic. We are as physicians, most people advise ECG in OPD with OPD. But what are the conditions which are life-threatening? We are going to listen. So, up to you, ma'am.
Can I request Dr. Rajiv Srivastava to please join the chairpersons? Dr. Rajiv Srivastava.
May I start? May I begin, sir? Yes. Good afternoon, chairpersons. Good afternoon, friends. I'm very grateful to be in the temple city of Bhubaneswar. Now, what I hope to do in this brief presentation is to mainly focus on ECGs, which happen in stable patients, the patients that you see in your OPD. But these ECGs are an omen of something sinister that can happen, something that an astute clinician can pick up and use to prevent that disastrous event. Of course, dear friends, this is not an exhaustive list, and there are experts in the audience, so please bear with me if many of these conditions are already familiar to you. Let's dive straight in. This first patient is Mr. G. He's a hypertensive smoker. Last week, he had some pain in his left arm. What did he do? He consulted Dr. Google. Now he comes to you. Please note, dear friends, at this point, he does not have pain. This is his ECG. You can write down in your books if you know what it is. If not, I'd like you to focus on V2, V3. Can you see the deep T wave inversion here? On the other hand, I don't see any Q waves. I see that normal R wave progression is preserved, the precordial leads. Again, there is no significant escalation, probably a little bit in V1, but hardly significant. What are we dealing with here? Pardon? So at this moment, we're actually dealing with something called Wellen syndrome. Now, apart from the ECG findings that I mentioned just now, there are two other important things to remember about Wellen syndrome. The first is that when he comes to you and he has this ECG friends, he does not have pain. That's the first point. However, you may get the recent history of angina, maybe a week ago. Now, Dr. Virmani gave me this topic saying life-threatening ECG. So why is this life-threatening? The fact is, Wellen syndrome, it's a harbinger or it's a sign of proximal iliac stenosis, which means it's a big risk factor for an MI. If you see an ECG like this, you must immediately refer for percutaneous intervention because these patients don't do well with medical therapy alone. Another thing which really hit my brain was, if you send him for a TMT, just to confirm your diagnosis, he's very likely to have an MI when the TMT is happening. So do not refer for a TMT. This is about Wellen syndrome. Let's go to our second patient. Mr. N was noticed by his wife last night what happened. He had a brief period of extreme agitation when he was sleeping, followed by unresponsiveness. His wife, being the good woman that she is, brings him to you. You find the history a little bit strange, but you get an ECG done and you see this. Any takers? So what I would like you to observe here is specifically concentrate on leads V1 and V2. Do you see this code ST elevation at least 2 millimeters cove ST elevation is there, and this ST elevation is immediately followed by deep D wave. This particular thing, this combination by itself is called Brugada's sign. But to call it Brugada's syndrome, it's not enough if that sign is there. You should also get some additional history. In other words, the patient should have had a history of syncope, or maybe had a history of PTAC, or he should have something called nocturnal agonal respirations, basically gasping movements when he's sleeping. Or he should have a family member who has either those core ST elevations or also a family history of sudden cardiac death. All this together makes you think of Brugada's syndrome. Again, why is it important? Why should we pick this up? Obviously, because since it's a risk factor for sudden cardiac death, second, it causes paroxysmal syncope with an endless possibility of wrong things happening. This nocturnal agonal respirations, if you don't know what they are deep gasping movements which occur during sleep. You can imagine how terrifying it would be to the person sleeping next to him. All the reasons you have to pick up Brugada's. My next will be much simpler. I hope you'll all pick this up. 25-year-old RK. What happens? He was running to catch a bus. He developed shortness of breath and he had some giddiness as well. You examine him, you think you hear something, you're not very sure. You hear an extra heart sound perhaps. And this is his ECG. And what is his ECG? Come on. It's everyone should say. Look, observe the LVH. He fulfills the criteria for LVH. Can you see? Look at the S wave, look at the R wave. Also, I would like to draw your attention to the dagger-like Q wave, the narrow Q wave, which is present here in lead 1 as well as the lateral leads. The narrow deep Q wave, this is called the dagger Q wave. What are we dealing with here? Young man, LVH, what are we dealing with? Hypertrophic cardiomyopathy. We don't say obstructive anymore, we say hypertrophic cardiomyopathy. Now, why is this so crucial for us to pick up as physicians? The first is, of course, because it's the most common cause of sudden cardiac death in the young. But this, I believe, is more important. There is a great danger of misdiagnosis or of missing a diagnosis. It's all too easy for someone who's not really focused to dismiss that LVH, to dismiss the Q wave as an old lateral infarct. So both us and our patients, we are missing a golden opportunity to pick up this HCM and put in something like an ICD and save his life. So this possibility of misdiagnosis is something you have to be on the guard. I hope I'm not going too fast or too slow. Is this space okay, friends? Thank you. Thank you, sir. Now, Mrs. A, she complains of episodes of palpitations. Like most women, she's perpetually stressed, and she ascribes those palpitations to stress. You get her ECG. Tell me, do you think her palpitations are because of stress or something else? Something else? Definitely, this is not a normal ECG. Please observe. I'd like you to see one or two things. One is there's a fairly widespread E wave inversion. You can see that there's a dominant R wave in lead V1 and also a slightly increased QRS duration in V1. It's not like V2, sorry, it's not very clear, a little bit is there. But if you just look at the arrow at the bottom, the second arrow at the bottom, just after the QRS complex, there's a small blip, and that is called the epsilon wave. All these together go for something called an arrhythmogenic right ventricular dysplasia. Why should we pick this up? This is something very close to my heart. Male physicians, do not dismiss your female patient's complaints as functional, because they can very well be organic, like this patient does have an organic cause. In fact, ARVD is the second most common cause of sudden cardiac death in the young. Also, it can cause right ventricular failure, it can cause dilated cardiomyopathy too. I'm okay for time, I think. So this was about Mrs. A. Our next patient was actually brought by his wife. She noticed that since the morning he was looking a little bit drowsy, he's complaining of double vision, maybe a little dryness of mouth. On the whole, it's a fairly sinister syndrome complex, and this is his ECG. Any guesses? Anything? Is this ECG normal? For sure, it's not normal. But I just want to tell you that there are two crucial signs. One is very clearly in lead 2, you can see the prolonged QRS duration. And also, if you look at AVR, you see a positive R wave which should not be there. This combination of prolonged QRS duration plus a terminal R wave in lead AVR is fairly specific for something which blocks the sodium channels, something which causes sodium channel blockade, in other words. You can see in this figure what happens is because the sodium channel is blocked, phase 0 of the atrial fibrillation, the slope goes a little bit down. And therefore, the whole period of depolarization is prolonged. This results in this clinical picture. And in this man, the cause was tricyclic antidepressants. I'm getting a clue to this because there was tachycardia, which goes to the anticholinergic effect of the tricyclic antidepressants. I hope I'm making some kind of sense here. Friends, any overdose is dangerous. All the more tricyclic antidepressants, as many of us who are slightly on the older side, we have often struggled to treat patients admitted with TCA overdose. Why? They can cause seizures, they can cause hypotension, metabolic acidosis, ventricular fibrillation, high fatality rate. So, even if it's a high fatality rate, when you pick it up earlier, you have a higher chance of succeeding. So remember, this ECG is typical of sodium channel blockade. I hope my audience is awake. Mrs. Stu is a known case of atrial fibrillation. She's been under follow-up from a physician elsewhere for a fairly long time. She presents to you with chest discomfort, not chest pain, chest discomfort, some nausea and some vomiting. This is her ECG. What do we have here? Look at this beautiful sign in V6. What is that called? The reverse appearance. See, what all do you see? You see, there's a fairly widespread ST depression, T-wave inversion, slight elevation, ST elevation in AVR. There's 1 or 2 ventricular ectopics because digitalis both suppresses and excites. And this picture of downsloping ST depression in the lateral veins. A clinical pearl for our juniors here. Please remember, suppose you have a patient of atrial fibrillation on digoxin, and then they come to you with sudden regularization of rhythm. That is a clue to you that maybe they're going for digoxin toxicity. This happens because of an AV block. So this is something which is a practical point worth remembering. Why is cardiac glycoside toxicity important? It can cause, like I said, it both excites and it suppresses. It causes both. It can cause both bradycardia and a ventricular tachycardia. Now, this is one of my favorite cases. Can I have your attention, especially to the clinical features here? Let's see if anyone can figure this out. Mrs. Z brings her daughter X to you. Recently traveled from a different country. She had a very traumatic past which through customs. She was questioned a lot. After she came back, she was found to be apathetic and dull. Do you think friends with children, was she just a normal dull teenager? Perhaps not, because when you examined her, you found certain findings. You found that the pupils were constricted, the respiratory rate was low, it was just 10, and the blood pressure was on the lower side. This is her ECG. What are we dealing with here? Pardon? Oh, fantastic. Sir, I mean, obviously, sir would get at the back. Yes. Opioid toxicity. So, what happens is when people are scared of customs, they just eat up whatever the things they're smuggling. So, she had opioid toxicity, which is on the list of drugs which blocks potassium channels, causing, as you can see, striking QT prolongation. So, this ECG can occur in many, many situations. In this particular, because of the clues that Sir so rightly picked up, the clinical features go in favor of opioid consumption. And we always have to keep the clinical features in mind, not just the ECG. I have to hurry up a little bit now. Now I'm going to go really, really fast because I'm going to put some simple ECGs on. Diabetes, hypertension, CKD presents with breathlessness. This is an ECG. What are we dealing with? Tall T is there. Hyperkalemia. We have hyperkalemia, we have a peak T wave, we have a slight P wave over here with some prolonged PR interval, and very, very slight QRS prolongation as well. This potassium was 7.9. Again, if I have to leave you with a message, for any patient who presents with a new onset bradyarrhythmia or an AV block or pulseless electrical activity, please keep hyperkalemia high on your list of defenses because it is treatable. On the same line, Mrs. says healthy lady, loose stools, vomiting, presents with weakness, myalgia. This is the ECG. What do we have? Come on. We have hypokalemia. Thank you, sir. So you can clearly see. What I'd like you to observe is this pseudo QT prolongation is actually a QU prolongation here. If you look at the first arrow at the bottom, it's because the U wave is also included, so it looks like a QT prolongation, but the next arrow beautifully shows a U wave as well. We'll keep this in mind because in a second I'm going to discuss it further. This man has two risk factors for a certain condition. One, he's an alcoholic, and second, he's continuously on proton pump inhibitors. He presents to your clinic with generalized weakness. You're tempted to say ADS and send him home. However, this is what his ECG shows. The risk factors are alcohol use and proton pump inhibitor use. We prescribe PPS left, right, and center. Do we know this? What is it likely to cause? What electrolyte abnormalities is likely to cause? Yes? Nothing else? Hypomagnesemia. So this ECG shows hypomagnesemia. And you see the prolonged PR interval. You see some runs of non-sustained ventricular tachycardia. You see some ventricular ectopics as well. Now, I'm just sitting in front of me. It's terrifying me from that screen over there. Mr. R is brought to your clinic by his mother. Typical characteristic history is given. He was swimming. Twice when he dived into the pool, he had a brief loss of consciousness. Mother said, this boy is scared of the water. Do you think that's all there is happening? Is there some condition which can be precipitated specifically? The book says by diving into water specifically. You get an ECG done because of the brief LOC, and this is the ECG. What is this? This is a long QTS, congenital long QT syndrome. So you can see that the QT interval is more than half of the preceding RR interval. You can see some dysmorphism in the polarization wave. You can see that there's bowing of the ST segment. The second arrow shows that. Important to pick up because we don't want to lose young patients because of something like what I'm going to come to in a second. The hypokalemia I discussed, the hypomagnesemia we talked about, and this long QT syndrome can all be complicated by torsades, polymorphic ventricular tachycardia, which can always degenerate into VFib, which is a life-threatening condition. Okay. Chairpersons, I'm just going on, but I can stop the minute you tell me to stop because otherwise ECGs will go on and on. Mr. J happened to just fall off his scooter. He's not really hurt. You're his family doctor. He comes to you saying, Doctor, I'm fine, but I have a little bit of chest discomfort. This is his ECG. Is he fine? What is striking in this ECG, if you look at the limb leads, is the low voltage complexes. And also, I can see a doctor making some signals there, yes. And also, what's it called? Also alternates. So this combination of low voltage complexes and versus alternates goes for a massive pericardial effusion. But what we are especially worried about here is the fact that this tachycardia is well, which means he's going into impending cardiac attack. Okay, I think I'm at my last one almost. I'm going to do this very quickly. Master Q has been gifted new Apple Watch by his parents. He's very proud of it. Mom looks at the watch and sees that the heart rate is worryingly fast sometimes. This is an ECG, and all of you know what it is. What is it? It's a WPW, which again is a risk factor for sudden cardiac death. The point I'm trying to make is you would have missed it if you hadn't done an ECG. And you will also miss all these diagnoses I talked about if you do the ECG but you don't know what we're seeing. The third point is when you pick it up, most of these conditions are treatable. Excuse me. So to summarize, I discussed certain conditions. I talked about Wellens syndrome, the deeply inverted T wave of Wellens syndrome, and I mentioned that once you diagnose Wellens syndrome, you must intervene. Percutaneous intervention, not medical therapy, no TMT. I talked about Hooker, and one thing, if any young man, any young patient has exertional breathlessness, along with LVH with a dagger Q wave, don't dismiss as IHD. Think in fact of hypertrophic cardiomyopathy and treat. Brugada syndrome I talked about, more common in the Far East rather than India, but we do see once in a while. I talked about ARVD, emphasizing the point that women with symptoms have diseases, they're not functional. And in the ARVD, we talked about QRS widening, epsilon wave, and T wave inversion. I then talked about the scary ECG of sodium channel blockade, which tricyclic antidepressants are just one of the many causes. There's a long list of drugs, but once you know what it is, you can figure it out. This looking at this ECG here, it requires immediate intervention. You have a dented T wave, you have QRS widening as well. I talked about the pulse alternates and the low voltage complexes of a massive pericardial effusion and a WPW syndrome also I showed you. To conclude, dear friends, the ECG, as we all know, is a low-cost, non-invasive method to diagnose and act upon potentially life-threatening. That's the point I'm trying to make. This person is coming to your clinic. You just did an ECG as a routine and you picked up something which is potentially life-threatening, which you can intervene and prevent. Many, though not all of the conditions I discussed, were in younger patients, which makes it all the more important for us to act fast. There is a fair amount of overlap among the ECGs of different conditions. One ECG could be because of various things like rugada, hyperkalemia, and everything. So when you are interpreting an ECG, always keep in mind the clinical condition too. Sometimes serial ECGs may contribute. So thank you very much for your kind attention, dear friends. My email ID is right. Knowledge will be shared. So I'm always willing to share the literature I gave my group. Thank you very much.
Thank you, ma'am, for a wonderful talk. And it is very beautifully organized and we're very much thankful to you. We can take one or two questions from the audience.
Ma'am, regarding LVA,
thank you.
Some full justice to the topic.
Thank you for the beautiful topic, sir. I enjoyed preparing for it. Thank you, sir.
ma'am, in the ECG you showed LVH criteria 20 of
I used S plus V in that program.
are V6 20 or as in we were 20 or 35 more together. LVH criteria was not.
It was not that you're talking about the HCM ECG, sir. 35. There are various criteria for LVH. This particular one, S plus R 35 I used. It was more than 35.
Oh.
Thank you. With our drag, we put my diagnosis of symmetrical tumors in all that is solved independently. Solved independently.
Thank you very much for your attention.
Thank you very much. There are the rarest presentation by Dr. Ismita. What wonderful. Now I will call the next speaker, Dr. Sajid Ansari. He will speak on role of echocardiography in primary care. Dr. Sajid Ansari is a cardiologist doing echo from, I think he has done his fellowship from Java Institute, Delhi, and he is a very good echocardiographer at Lucknow. Welcome, Dr. Sajid.
Thank you, my seniors, my friends, for giving such a wonderful opportunity to bring my career in front of my friends are here. Most of time they present my report. First event to me, role of physician in evaluation of echocardiography. Especially primary care physician. I mean, what does it mean? We know echocardiography, this conference is usually going to hold in 2 to 3 days. So I am trying to summarize in 20 minutes what we will do as a non-invasive cardiologist and what is the responsibility of our physician friends. Don't stuck with a tubular vision on the injection sites. That is usually most problematic thing while interpreting the report of echocardiogram. I will come across with few my PPT and my presentation why it is wrong just to that is definitely one part. We can't say like this, but that is not the limit. So anyway, when we are looking for the echocardiography, I think sequence of events is very good. Initially, some clinical sign of murmur, then speak about it. We are not going to speak about it in cardiography. So let us see LV function, systolic function, diastolic function, RV function, different chamber analysis. Think of this wall motion abnormality that is the most important part. Usually, physician asking for this ejection fraction and comment on the wall motion abnormality. But on the same time, because in the echo, this is not mentioned what is other causes of wall motion abnormality. So always this should be in the mind. So what I am telling, clinical correlation, clinical echocardiography is very important.
Suppose that a patient with you without any sign and symptom of ACS, and your echocardiography report is there is a wall motion abnormality. So you can't say that my patient is an ACS. Let us go and take their history. Either patient is a history of ACM, having some background diseases, having possibility of cardiomyopathy, or contrast. Patient having typical history of ACS. Your ECG is normal. You know, in the first 1 hour there is no significant change in the ECG. But usually, if you are a good echocardiographer, wall of abnormality, you can pick up. Even echo is the normal, then this is your moral responsibility to you treat the patient as ACS. So, while making a diagnosis, you can't make it one modality of investigation. This is your diagnosis, and you must go for this. Echo is one of them. So, at the same time, you see for cardiomyopathy, different type of cardiomyopathy, and easy way to diagnose hypertrophic cardiomyopathy, ARBD, HCM, DCMP, HPF, FRF, whatever it is, restrictive versus non-restrictive cardiomyopathy, pericardial disease. Evaluation of this factor problem is a very important one, especially mitral aortic valve. So, and at last, before 5 years, this was a very rare that patients should go for this strain medical training. But right nowadays, even I am practicing in the Lucknow, and before 5 years, it was only the institute. But at least I know we 5 to 10 person doing this strain imaging spectral tracking routinely, and that is a very important part while evaluating the patient. This is some important fix in Delhi you are finding in the echo that these are plans view one is here. It's a plan view showing left atrium, right ventricle, left and right ventricle. Other is going for the M mode and calculating his ejection fraction. Friends, there is so many methods for the calculation of ejection fraction, but never in the report mention I am calculating by 1-3 method. But believe me, when your patient is having wall motion abnormality and some bundle branch valve, as a ectopic rhythm, if someone is calculating this ejection fraction by simple linear method, that is totally wrong. Because you are interrogating the sample size at the one point and you can't calculate this ejection fraction. So, on the same time, you take the care by which method ejection fraction is going to be calculated. Anyway, coming to systolic function, gender quantification. By doing the echo, for me, the most important part is my eye assessment of the L. Eye assessment of the L. How mitral valve is separating water coagulation. How is RV functioning. So, starting from this ejection fraction and think beyond the ejection fraction, see for the endpoint of concentration. Mass is a very important parameter, usually not mentioned this mitral angle planes systolic exertion. And suppose that your echocardiography mentioned that your mass is like 10, 11, 13 like this, then you can multiply it by 4.6 and you will calculate the ejection fraction. That will be more and more better than this calculated traditional way. Then fractional change, fractional separation, visual assessment, for me is the more important. Then MPI, DP by DT, tissue Doppler imaging, routinely we are doing tissue Doppler imaging. We know in the mitral valve there are two types of there medial mitral and lateral mitral. And theoretically, imagine when the LV function is reducing, mitral velocity, this vertical velocity, longitudinal velocity is reducing. So any patient with a reduced TDI from a systolic wave, definitely a patient having a lower ejection fraction or lower systolic function. But one thing keep remember that if all function is dependent on preload, afterload, and what the rhythm of the patient. Usually when patient is a sinus rhythm, this all is a very easy way to calculate. But when patient is in the atrial fibrillation, having frequency of a topic, having left particular branch block, then what to do? One, Dr. Raji was here and is a very good cardiographer. One thing usually not doing, but MPI, myocardial performance index, this is one parameter. A single parameter you can calculate the systolic function, there you can calculate diastolic, parameters. This is independent of preload and afterload. And how to calculate, just to giving 2-3 minutes. We need to calculate three variables, isovalve contraction time, relaxation time, and ejection time. Normally it is up to 0.42. If it is coming somehow more than 0.42, this is normal. Now coming to right ventricle, and one thing, friends, suppose I am dealing with patient of pulmonary hypertension. Suppose I am dealing with a patient of mitral stenosis. What is one thing our cases are the rejection fraction? No way. If I am dealing with a patient of this mitral stenosis, our inpatient should be given one mitral valve area, what level of calcification, what is the condition of regurgitation, what is the PA pressure, how is the IVC flow, how is the collapsibility. So always you correlate echocardiography in terms of the clinical sense. Anyway, we have, and usually in the echo, this right ventricle function is omitted. So this is a modified four-chamber with what we call a focal four-chamber where RA is looking dilated. And this is a very important way to calculate the PA pressure. I will show in the subsequent slide. While you are calculating this diastolic function of left ventricle, you can calculate diastolic function of right ventricle. But usually not very important, but one thing is important. Suppose that I am dealing with patient of primary pulmonary hypertension. Usually this diagnosis is given by this echocardiography and sending patient for the cath and so on and so on. So I am dealing with a patient with a primary hypertension. What is my responsibility? So keep the more and more focus on R and R. What is characteristic finding? LV is small, typically D-shaped cavity, paradox movement of IV, septum, RA, RV dilated. So as a while doing echocardiography of this type of patient, I am going to calculate RA strain, RV strain, RV fracture shortening, and then top stage the one parameter, very simple parameters. And if you are keen to know the right ventricle parameters, you ask your cardiologist to mention the top stage. Normally this should be more than the 22-25 like it. If there is a reduction in the function of right ventricle, longitudinal movement is reduced and top stage is reduced. So very simple. So you have tricuspid annular systolic exertion that is reduced. Coming to pulmonary hypertension, very easy way just to calculate the TR velocity like this, and with the TR velocity square, and then you add the RF pressure. Then how to calculate RF pressure? I think one is just to see the JVP, and that's the most subjective. Suppose one is telling no JVP is red, I am telling not, it is not red. So what just to see the IVC and collapsibility of IVC and what is size of IVC. If it dilated more than the 10 mm, collapsibility less than 50%, more than the 50%. So usually if it less than the 50%, and size less than the 10 mm, RA pressure is 10 more than that, 50%, 15 to 20. So just to PR velocity and collapsibility of this IVC. Now conditions come and then you know tricuspid regurgitation, then how to calculate PA pressure. Or when there is a hyperdynamic circulation, anemia, pregnancy, does it mean that every female is having pulmonary hypertension? No. So you need to focus on the other point like pulmonary valve acceleration time. What is diameter of RVOT, what is size of right atrium, and what is collapsibility of this IVC. So I mean, while making this, one thing you know, when PA is more than the 35, 40 different literature, you are having this pulmonary hypertension. But as a cardiac person, non-invasive, I am giving my view, clinical view, that this is not only one parameter. If someone RVOT is dilated and their PR velocity is less, suppose you are dealing with abstinent anomaly patient, there is low pressure TR rate. So if but R is usually dilated, IVC is usually dilated. So in total you need to give, so there is a possibility of any case suspicion of pulmonary hypertension when TR velocity is a little bit high, more than 2.83 like this. RA is dilated, RVO is dilated, pulmonary valve acceleration time is high. This is one clue. But when this is not the exact effect, that you go and correlate your patient clinically on what IV size and what the collapsibility of the patient. certain eccentricities. What happens in the pulmonary hypertension? Typically, if you see the echocardiography, this RV dilated and LV becomes small T-shaped cavity, and because of increased RV pressure, a paradox movement of septum. So all of these things should be always kept in the minds. So coming to valvular abnormality before diagnostic function, that is a very important part in the while diagnosing this ischemic heart disease and ACS acute coronary syndrome. So one beauty while doing the echocardiography, you can pick immediately if you are keen and you know this different territory, this blood supply. But on the same time, you should be kept in the mind what the causes the valvular abnormality is there, but there is no ACS. But one very important thing regarding echocardiography is in the first 6 hours, when you diagnostic clinical diagnosis, yes, my patient is having unstable angina. What happened in unstable angina? Usually you see no major changes. Troponin not raised, resting early function, ejection fraction is looking normal. So, I mean, and if you're not going to treat the patient, might be patient having double and triple vessel disease. So here is strong suspicion when you are having a stroke for ACS, either ST or non-ST, you might use send your patient for the echocardiography, and first 6 hours is the golden time to pick the valvular abnormality when your ECG is not making this changes and troponin is not raised in the early phase of time. So this is a very clinical utility of this echocardiography. Coming to diastolic function, and usually this is one of my seniors, but I was talking outside, very seniors told me I was looking in the echo to do things just to ejection fraction, wall motion, and nothing else. But you know, here the majority of international diabetologists friends here, and you know whether diabetes is uncontrolled, hypertension is uncontrolled, rather than the systolic function, this predominantly first affect the diastolic function. In the hypertension, usually ejection fraction is normal or supernormal. This effect on this filling pressure, left atrium and pulmonary artery pressure, PCWP. So basic of diastole, you remember what is happening and what we are looking in the diastole. In diastole, if you remember the physiology classes, when aortic valve is closed, then ventricle start to relax, then rapid filling of blood from LA to LV, then some period of diastasis, and then last active contraction. These 4 things we are regarding echocardiography and going to interpret clinical. So first isovalvular relaxation time, IVRT, then rapid filling, LA to LV, that is normal pattern, then period of diastasis and late atrial contraction. In relaxation at normality, and the feeling pressure is high, these things is going to be relaxed, and this is not only sufficient, at the same time this need to calculate this annular velocity, mitral valve propagation velocity, pulmonary venous flow velocity, and hepatic venous flow velocity. This is some complex slide, so I will make it simple. So I need the mitral annular velocity. TDI is a very simple actually in every echocardiography report. And this is the way by you can calculate is either patient in grade 1, grade 2, and grade 3 diastolic dysfunction. In grade 1, filling pressure is usually normal, little bit grade 2 filling pressure is high, PCWP high, and high TR velocity. And grade 3 is a restrictive pattern of diastolic dysfunction where usually very high in filling pressure. And this is the more and more dangerous than a health patient. The usually problem I am facing with the patient of my surgeon and anesthetics. Yes, injection fraction is 70%, I am 70% for this operation theatre. And grade 3 diastolic dysfunction and patient with high and filling pressure, there might be a tail on the table. Injection fraction is looking the normal. So filling pressure is so important in this kind of patients. So in the flow velocity, we are looking 3 waves, systolic wave, S wave, E and A, and that's like comparing this with the mitral flow velocity. This normal value is, I am talking about 2 different annulus, so the medial mitral, lateral mitral annulus. So lateral mitral annulus is increased, so its velocity is little bit normally high. So lateral is higher than the medial mitral annulus. That's why in condition like constrictive pericarditis, there is an annulus reversal where lateral mitral annulus velocity is reduced and medial mitral annulus is increased. So this should be kept in the always in the mind. I will skip this slide and make it simple. Coming to left atrium, this left atrium turn a glycosylated hemoglobin of the diastolic dysfunction and it reflects the burden of heavy diastolic feeling. Why I'm mentioning the diastole? Because and the diabetes, the earliest changes in diabetes, some changes in diastole and this calcium resistance abnormality. So especially when you are diagnosed with your diabetic and hypertensive patient and focusing on this exercise, you are missing the things which is going to progress. So it has been shown that the sign in the volume of LA in the diastolic dysfunction progress. Mechanical stage of LA induces hypertrophy of LA, myocytes leading to fibrosis, predisposing to atrial fibrillation. In hypertensive heart disease, the high incidence of atrial fibrillation is there. Even low atrial fibrillation or 18 to 20%. What the reason behind this low atrial fibrillation? Only thing is increased LA pressure. The dilated stitching of this atrial fiber patient started development of atrial fibrillation and very important is for the development of thromboembolic complication. So there is three types of diastolic dysfunction rather than making some simple. Yes. Grade 1, what does it mean? As I discussed, early feeling pressure is high than the atrial contraction. In grade 1, this is reverted. In grade 2, diastolic dysfunction. Sometimes E or A is normal and sometimes E is little bit high. Grade 3, early feeling is entirely reduced because of ventricle become stiff. Atrial contraction is very high and is usually associated with high feeling pressure. And grade 4 is the grade 3 restrictive pattern diastolic dysfunction, which is reversible pattern, is not yet reverted by valve. This is why this diagrammatic representation of this dysfunction in the grade 1 is used. Speed is less than A, grade 2 is greater than A, grade 3 again is greater than A. But when you give the valve in the grade 4, this is not good to deliver. Mitral flow velocity, this tissue Doppler reduction in this early phase velocity is all category, but as the disease is advanced, this causes more reduction without changing the valve. Then the calculation of pulmonary and mitral flow, MVP, what regarding propagation velocity, but in a clinical utility, you should compare three things while addressing the diastolic dysfunction. What the ENA, what the ratio of ENA, what the TR flow velocity, and what the PCW, pulmonary capillary base pressure, and left ventricular diastolic pressure. So you can inject this. Grade 1 IVRT, prolong the initiation time, prolong, then mitral air duration, pulmonary valve air duration, this depending on the left ventricular diastolic pressure. But two things always should be key. IVRT prolonged normally should be less than 100. TT more than 200, normally should be less than 200, and E by E ratio is less than 1. This is the grade 1 diastolic dysfunction, and grade 2 diastolic dysfunction, E is reverse, E greater than that. DT is reduced because of the grade 2 diastolic dysfunction. Again, this ventricle get stiffer and stiffer, IVRT is reduced, and grade 3, as I discussed, usually the constrictive pericarditis and advanced stage of hypertension and dilated cardiomyopathy and have like a picture. And if you are giving this Valsalva or this lingonnitrate, this is usually not going to reverse on this advanced stage of this diastolic dysfunction. This is the restrictive pattern of feeling pattern where this, this is the most dangerous than the hypertension patient here, feeling pressure is very high, left and diastolic is very high. IVRT is very short, less than the 70, and so this kind of patient always kept in high cautious while managing this patient. Pulmonary flow velocity, all the same time you can manage it. So I think if I summarize my talk briefly, just while reading the report of echocardiography, not to focus on the ejection fraction, let us see the stroke volume, left ventricular diastolic and systolic volume. And at the same time, you give some time for this diastolic pattern, and that usually early subclinical changes in the diabetic and hypertensive patient. That is set of patient by which we are dealing in day-to-day practice. And clinical correlation is more important. We can't say that this echo is something like we can make it ultimate. No, we can't make it ultimate. clinical correlation starting from history and it was important to make it a clinical sense by managing the patient. Thank you, result from my side.
You have covered every, and I think every part of cardiography in such a short time. The only problem is when you get a patient who has got fascimeter stress or is very, you just write that echo window is very poor. How do you manage that? And the other thing is regarding LV dysfunction, in tissue doctor you have not mentioned that E upon E dash, if it is more than 40, it is a definite sign of LV dysfunction. If you do tissue doctor study and E upon E prime is more than 40, then it's a very important sign of LV dysfunction. The other thing is how do you manage the patients who have got very poor echo window?
Yeah, I think I have not mentioned so many things. Regarding 20 minutes, I want to cover all but I think a question is very right. When you isolate a patient and when crowding of ribs is there are two things. One patient is very lean and while doing the echocardiogram, we are not able to put the probe in the intercostal space. So practically, I am going to epigastric route, putting the probe on the epigastrium. You can visualize LP little better when the crowding of ribs and leakage and chest. So I am doing a little bit, expending more time while doing the echocardiography, not doing echo in the 5 minutes. These two things I am practically doing, and I'm able to get it done in a patient. Second most important thing you asked me, and usually I try to emphasize, because of in 20 minutes, usually physician and primary care physician, just looking at, I've seen so many patients, they came with a chest pain and shortness of breath, ECG normal, echo done here 70%, and from a prominent physician, they told, no, you need job, you are all right. And after few times they started to develop some ECG and subsequently injured and some patient having critical vessel disease. But at the time of presentation, when you see their diastolic parameter, that usually not mentioned. And if you are keen that your patient having some problem, you can go for the diastolic stress test also. That's very simple and without any extra cost. And if possible that clinically your patient having strong suspicion reaction fraction is looking now, just to subject your patient for expected tracking the strain imaging. Easy way, just little bit expensive. If I am doing it and my patient is my patient, I am operator or carrying for the free and see the strain imaging. Rejection fraction 70%, but GLS reduced by 10%. Yesterday I was doing echo of the mitral stenosis, just dilated and PS was just 40. But when I compared the MA strain with the Y strain was just 2%. That was ideal candidate concentration for the MPR. So overall presentation is important. Regarding you mentioned this feeling pressure, my practice and those which are doing practice entirely in the cardiology, either non-invasive. Mentioning feeling pressure, giving focus on the feeling pressure is more and more important than the only focus on the ejection fraction. Someone is having more E more than 20, 25, definitely in the worst of this prognosis, either HFrEF, believe me, 1% of HFrEF ejection fraction 40%, E by E prime 10, and 1% of this HFrEF mid-range ejection fraction with EF 50% and E by E prime 25, that guys are getting worse and worse prognosis because feeding pressure is so high. Chronic feeding is entirely the dash, so that is going to reverse in the future. Thank you.
Sir, one question. Should echo be advised to every patient of hypertension and why?
I think why do we advise echo? I think these are millions of questions. In hypertensive patient, what we are looking with the patient? It's a arithmetic number that is study you are 160 by 90 today, you are 140 by 90. You go and you are all right. Ultimately, in the era of CBD, we are dealing with the patient. What we are, I mean, in our theory, what we are daily discussing, Just to calculate ACPD, look for their respiratory, look for their intermediate thickness, let us see their feeling pressure. So if this is our in day-to-day practice, why can't we adopt in our practice? And initially, this Indian Cardiac Hypertension Guideline is going to publish, and I was one in the CV system there, cardiovascular part from India. There were 3 doctors. So I put this the same point that echo should be a primary choice of investigation in the hypertensive patient. Then there was an objection why it's supposed to be secondary investigation. Then reflecting, I asked, then why you are asking echo with every patient? If you are suspecting ECG is sufficient to know the chamber hypertrophic pressure and that will be gradient, then why you are asking with every patient? Usually all physicians asking. So just to before establishment of hypertensive heart diseases, you can judge their LA symmetry, LA parameter, LA to LV feeling pressure, how patient is going to be. Suppose that your patient is having no hypertrophy, ECG is coming up, and you guys having LA feeling pressure. Even in your cocktail of you guys little bit diuretic, the feeling pressure will reduce and patient will get symptomatic benefit. So that's why I'm asking for the echo, that evaluation of the LV systolic and diastolic function, prognostication of the patient, and even rectification of our treatment. That we know hypertrophy is reduced by ACE-ARB, that's the ultimate. But what else needed? That's what I must.
Thank you. Thank you, Dr. Ansari. Can we have the other two speakers, Dr. Akash and Dr. Smita, for the felicitation?
Side. Hello, take a side.
We also have a felicitation for chairpersons.
Photo niyo.
We have some. So that was an excellent session. It's heart matters. So now, it's like jack of all trades, the hospital session. So to begin the session, I call the chairpersons, Dr. T.C. Shah, Dr. Brahmanand Das, so Dr. Brahmananda Das, Dr. Namita Mohanty, Dr. Dinabandhu Sahu, so I request the chairpersons to call the speakers for the session.
तब तक खत्म हो जाएगा तो हम सारी को
Thank you.
Because I'm not there. I'm Dr. Brahmananda. It's a very exciting session in itself. I have not come across the topics in my career at all. So this is hospitality. Okay? Hospitality. So the speaker of this session, the first speaker is Dr. ACP Chandra.
Thank you.
And he will be speaking on how should I protect kidney in hospital care. Who will take care of the kidney? You, me, or the patient, or the doctor? Okay. Thank you very much, dear chairpersons. At the outset, I would like to thank Professor Anup Maheshwari for inviting me for this session. And more thanks for giving me such a wonderful topic, and I will try to do justice to it. So, dear friends, the question is how should I protect kidney in hospital care? So, how many of you would agree that sometime or the other way to say, more than commonly, we do see patients with acute kidney injury to some extent or the other in our practice. Those who are in hospital. So we see it very often. We need to learn how to protect it. Most of the time we know that this patient has got acute kidney injury. We recognize it, but we are not doing enough to protect it. So the best way is to learn from a case. You can correlate this case in your clinic, in your hospital very often. I mean, an elderly lady has come to you in a surgical ward, say something, left iliac fossa, right iliac fossa, maybe appendicitis, maybe diverticulitis. And when her EGFR is somewhere near 35, she is hypertensive, taking some ACE inhibitors. She has got she has got diabetes, she is on metformin. And there is some pain and you will give some antibiotic to, okay, there is some infection in your abdomen, take this antibiotic. Well, she takes this, although she has got some dysuria, you give some antibiotic. And it often happens that because of infection, the dietary intake is decreased. But patient continues taking medication. Doctor, हम दवा रेगुलर ले रहे हैं और दवा नहीं छोड़िए. Now this happens and unfortunately the condition worsens and the patient comes to you with complaint of fever and hypotension. Her heart rate is 120. So she is in shock. Now you do investigation. She is having stage 3 AKI. So I will be discussing about what is the staging of AKI. In these conditions, she has got hyperkalemia, acidosis, and high metabolic acidosis, and her CRP is raised. Now, for infection, she is being treated with some antibiotic, including gentamicin, and for treating hyperkalemia, you are giving insulin infusion along with glucose. Since her blood pressure is low, a fluid replacement is done, and the fluid replacement is done up to the extent of 6 liters in 24 hours, particularly in a lactate or Hartmann solution. Now, over 24 hours, her creatinine has risen further. She becomes increasingly hypoxic. Radiological evidence is of pulmonary edema. She is transferred to ICU. Mechanical ventilation occurs. CT scan is done. She has got perforated sigmoid diverticulum, maybe perforated appendix. That is all. Patient is in shock. Hemicolectomy was done. She was put on vasopressor. However, she suffered cardiac arrest and she didn't recover from that. So this is a common story, and I believe those who have been working in hospital might have experienced such case once or more in their practical life. What do we learn here? What we learn here is the background.
78-year-old lady, ACE inhibitors, hypovolemia, infection, she is at increased risk of AKI. There was background pre-existing CKD, elderly patient with comorbidities. We continued nephrotoxic drugs in this patient. Number one. We added some antibiotics which are usually contraindicated in stage 4 or stage 5 CKD, which had potential of causing hyperkalemia. Then we over enthusiastically gave large amount of fluid and 6 liters, whereas the patient's blood pressure was not responding. Now, what I could have done different? The first thing is that effective reosteogenesis of blood pressure should have been done. If we are not able to achieve mean arterial blood pressure of more than 65 by initial infusion of 2 liters, this shows that the illness is severe, some vasopressor had to be used. So in absence of obvious fluid or blood loss or cardiogenic shock, such patients should be regarded that patient was in a septic shock and vasopressor therapy should have been started. And in this case, additional fluid, since it failed to improve the perfusion pressure, that ultimately led to pulmonary edema. A judicious use of fluid should have been there. So this is what we learn out of this. So finally, this case demonstrates the high mortality associated with AKI, where renal insult is simply a talisman for serious underlying pathology. So let us understand what this acute kidney injury is. We have to protect it. So acute kidney injury is common, expensive to manage, and prolongs hospitalization. Only 50% of the patients deemed to have good standard care, and what it has been seen that if you do proper assessment of these patients at the admission, almost 60% of the patients who are expected to get AKI can be diagnosed. And in up to 20% of patients, you can prevent the AKI. So what we want to say, that inadequate, so 2/3 of the patients had significant level of AKI before the diagnosis. If you are able to have red flags, which tells us that which is the patient which is at increased risk of AKI, you can prevent AKI in up to 2/3 of the patients. And obviously, more severe AKI will have severe outcome. Now, AKI is defined by acute reduction in kidney function as identified by increase in serum creatinine or reduction in urine output. A simple way how to tell the severity of AKI. If serum creatinine increases by 50% to 100%, 1.5 गुना से 2 गुना हो जाए, और urine output is less than half ml per kg body weight per hour. 60 किलो का आदमी है, 30 ml per hour से अगर कम urine output है for more than 6 hours, patient is already going in AKI. If it is prolonged for 12 hours, it means severity is stage 2. And if it is prolonged for more than 24 hours, or if it needs renal replacement therapy, that is the stage 3 of the kidney failure. Why AKI is important? Let us understand this. If a patient develops AKI and if a treatment is done, full recovery may occur, but unfortunately, there are substantial number of the patients who would go in end-stage renal disease. It's said that even if there is recovery from AKI during hospitalization, their kidney function should be monitored at least for 2 years, because risk of progression to CKD is very high in patients who develop AKI during admission. Now, if you want to prevent AKI in your hospital, you should know what are the risk factors. So it is important to recognize that 2/3 episodes of AKI develop prior to hospital admission. So patient has got risk factors. Some insult has already started before coming to hospital. So if you know the risk factor, immediately at the time of admission, you will work to prevent the further damage. So if there is history of volume depletion like dehydration, blood loss, hypotension like sepsis, medication or cardiac failure, these are the patients which may develop pre-renal or hypoperfusion associated acute kidney injury. There are certain intrinsic renal causes like acute tubular injury, interstitial nephritis, glomerulonephritis, and vasculitis. Post-renal volume depletion like bladder outlet obstruction, bilateral ureteric obstruction, and obstruction of the single functional kidney. Now, this is one of the important slides, a busy slide, but I would like to explain it to you all. So, this is a flag or algorithm which is designed in Ireland. This alerts will automatically identify patients with AKI and enhance clinician ability to recognize AKI. So there are two. You have to identify those patients who have risk factors for AKI and those patients who have developed AKI. So risk factors, patient has got CKD, that is EGFR less than 60, age more than 65, or comorbidities including ischemic heart disease, congestive heart failure, or diabetes mellitus. Or acute onset, which includes sepsis, perioperative period, illnesses like hypovolemia, hypotension, or nephrotoxic medications. Those patients who are already taking nephrotoxic medications. So these patients are high risk. If there are more than two, immediately make a flow chart that the kidney function of these patients, urine examination will be done every alternate day in these patients. Now, if patient has got established AKI, you have to investigate early, then you have to restore kidney perfusion early. So you have to optimize the blood volume. Bolus of 200 to 500 ml of crystalloid has to be given so that you are able to achieve systolic blood pressure of more than 100. A maximum of 2 liters of fluid should be given within 2 hours. And if you don't get adequate blood pressure response, then some other diagnosis should be thought about and vasopressor should be used early. A little bit about pathophysiology. Why does it occur? There is a dynamic control of glomerular pressure by pre-glomerular arteriolar resistance and dilatation and post-glomerular arterial resistance. And they are affected by prostaglandins and RAS inhibitions. Now there is a dynamic play and there are certain drugs which impact it, and because of which the normal assessment which occurs to protect the kidney does not happen. And that usually happens when there is hypovolemia or when there is cardiac cause or when there is sepsis. Now, how to prevent AKI? The first thing I told you that almost 60% of the AKI that occurs in hospital starts even before admission to the hospital. So we need to learn that those patients who have got CKD, that is ejection fraction less than 60%, those nephrotoxic drugs should not be used. There should be instructions given for temporary cessation of those nephrotoxic drugs who are at risk of developing AKI. Simple formula is avoid that is diuretics, ACE inhibitors, ARB, metformin, and NSAID within the community so that when the patient comes to you, patient doesn't develop AKI. Now, there is a risk assessment chart which has to be done. Now, if there are comorbidities, I have already told about ischemic heart disease, congestive heart failure, diabetes mellitus, baseline GFR less than 60, systolic blood pressure less than 100, or receiving IV fluid or nephrotoxic medication. So, if the score is more than 3, patient is at higher risk of AKI. Don't wait for AKI to develop. Identify those high risk patients early and take preemptive action to prevent acute kidney injury. The factors included age more than 65, CKD, comorbidities like cardiac, liver, diabetes, nephrotoxic drugs, diagnosis of sepsis, hypotension, deteriorating early warning signs. Then another common clinical situation where we do see AKI is peri-operative period. Very often we see that patient goes for surgery and then there is AKI, there is increase in creatinine level. Here also we need to recognize these patients who are at increased risk. Because at times during surgery there is volume depletion. Patient is kept milk orally. Now the background is that patient has got higher risk or patient you are doing elective intra-abdominal surgery or major vascular surgery, emergency intra-abdominal surgery. These are the risk factors. And if risk factors are more than 3, you have to do preemptive management so that you can prevent AKI. So daily urinary examination has to be done. You have to stop antihypertensive medication if blood pressure is less than 135/80. And SAID and aminoglycosides should not be used if EGFR is less than 13. ACE inhibitors, ARBs, should be stopped during surgery and should not be started at least 48 hours after surgery unless EGFR is well controlled. Because continuing ACE inhibitors and ARB is one of the common cause where we do see peri-operative acute kidney injury. And if hypovolemia or hypotension is there, you have to correct it appropriately. And time and again saying appropriately means hypotension should be treated appropriately. Simply fluid is not the answer. You have to give bolus of fluid, see the response, bolus of fluid, see the response, and if blood pressure does not recover even with 2 liters of crystalloid within 24 hours, you have to decrease the rate of fluid replacement and add vasopressors appropriately at appropriate time. So perioperative AKI, optimization of fluid balance. At times the patient is nil orally, you have to give adequate fluid, optimization of blood pressure. So hypotension, systolic blood pressure less than 110 or mean arterial pressure less than 65 needs urgent assessment and treatment with IV fluid and vasopressors. Medication review, avoid those drugs which causes hypotension, avoid those drugs which causes acute kidney injury, identify the risk factors, manage the risk factors. Once the patient develops AKI, clinical assessment is appropriate to find out what is the cause. Unless you are able to find out the cause and remove that cause, whatever treatment you do for AKI is not going to be successful. So AKI in setting of resistant hypotension suggests that there is underlying sepsis. You need to identify which happened in this lady I was talking about. Despite 6 liters of fluid, hypotension stayed and she developed pulmonary edema, she had to go on mechanical ventilation and ultimately she developed cardiac arrest. So intrinsic renal disease should be considered and the effect of AKI should also be assessed, particularly to assess the to avoid the volume overload. Then comes stick test that tells you about what is the cause. Pre-renal head, it will be concentrated urine would be there. It's intra-renal, intrinsic renal, then you will have some blood cells or RBCs in that, vasculitis and other things should be evaluated. Evaluation of kidney functions like anemia, thrombocytopenia with normal coagulation profile should prompt a search for hemolysis. Patient develop AKI, early management should be stabilized. So restore renal perfusion, I have talked about it time and again, proper adequate fluid resuscitation along with vasopressors wherever it is needed. Optimize intravascular fluid volume, so patient may be in hypovolemia, in that case you may have to give adequate fluid. There are certain conditions in which AKI developed during euvolemia. You have to identify what is the cause. Mostly intrinsic renal causes there, and you have to treat that. There are certain cases of AKI where hypervolemia may be there, that has to be evaluated. That includes raised JVP, peripheral and pulmonary edemas, most of the cases would require dialysis, hemodialysis or ultrafiltration. AKI and hypertension, blood pressure should be targeted. We should keep mean arterial blood pressure to more than 65 to avoid those drugs which causes hypertension or which disturb the renal autoperfusion. Prescribed medicines safely, so those drugs which interfere with renal infusion should not be used. Drug dose reduction should be done wherever it is appropriate. For the benefit of time, I'm going a little bit faster. Drugs requiring close monitoring should be adequately done, and drugs that aggravate hyperkalemia should be avoided in background of acute kidney injury. Now, with this, I will go to the second case and try to understand how things have differed when we have learned something. So he was a 60-year-old male admitted into a medical ward with 2-week history of cough, arthralgia, and reduced appetite. He was prescribed doxycycline and NSAID for 1 week. He had a background of type 2 diabetes, hypertension treated with ramipril. So once again, this patient is a high risk factor. This patient was admitted with fever and hypertension with raised creatinine and AKI. Obviously, sepsis was thought to be the cause, but what do we see here? Blood pressure is not reduced. So X-ray showed multiple nodular opacity. Despite treatment with antibiotic, renal function deteriorated. A repeat urine analysis was done. 4 plus blood and 3 plus protein was seen, and then subsequent vasculitis was seen. Why I have given this example? All AKI is not sepsis or shock. Fluid is not always the treatment. You have to identify the cause and treat it appropriately. So his presentation was consistent with granulomatosis with polyangiitis. He was empirically treated with pulse with high prednisolone and IV cyclophosphamide. Subsequent renal biopsy confirmed vasculitis, and 2 months after the presentation, eGFR was 50. His coronary nodules resolved. This is what we learned. This patient was initially suspected to have AKI due to combination of pneumonia and concomitant NSAID and ACE inhibitor. However, there were 3 key pointers to the possibility of intrinsic renal result. The lack of hypotension insult during his hospital admission, presence of deficient blood and protein in urine, and the failure to improve despite appropriate antibiotic therapy against pneumonia. So the message that I wanted to give, last week only I had 70-year-old diabetic lady, hypertensive. She was given some analgesic for her knee pain by osteoarthritis, and she had UTI. She developed typical sepsis. Now, if you are suspicious and you treat it early, you are able to prevent it. So the message is that up to 60% of AKI is already present at the time of admission. We need to find out those patients who are at high risk and treat them appropriately by finding out the cause, and you can prevent the kidney damage and the patient. Thank you very much for your patient hearing.
Thank you, Dr. KP, for your excellent delivery. You are very well taught with the clinical diagnosis, risk factors, and how to manage. So now the session is open for the question or any comment.
Yes.
First of all, that was a too good a presentation. Very clinically relevant and very a lot of learning points. Only comment or suggestion I have is most clinicians, especially the resident levels, the consultant comes in most. The residents who are working in critical care units and IPD, and they take moment-to-moment decisions. And sometimes the news teachers are not doing it. So what I felt is rather than monitor creatinine, it's something we read but we don't practice. If you start monitoring creatinine clearance, it's something to pick up much earlier. Changes can be made much earlier in the therapy there. What I do in my setup is I get a nephrologist in one body. Because some they have more sensitivity towards changing the dosage of a lot of medicines. Like simple tips that we nowadays stop using cholesterol as an infusion. A lot of kidney damage. My own dad developed kidney failure because of that. We started using nebulizations. So I don't know the efficacy, but that's something that we started using back home. So A couple of things on the sensitive, on the slow activity looking, there are a ton of analgesics, ton of NSAIDs which can be removed, which there are a ton of ACE and ARBs are highly misused. They just continue on in the therapy in the critical care without realizing that they are responsible for killing it. So some lot of pointers are there which can actually prevent AK.
Thank
A
you.
lot of lessons to be learned.
I couldn't agree more. Couple of things what you said. Probably we are less sensitive to changing creatinine, but if you convert it to EGFR, we become more sensitive. Number one, changing EGFR is another important thing. The earliest thing that you would see is urine output. Usually change in creatinine takes 24, 48 hours. But once renal shutdown occurs or renal function deteriorates, the first thing that you would start seeing is decrease in the urine output. So a very vigilant monitoring of urine output will let us know even before the creatinine rises. Number one. Number two, blood pressure monitoring. Maintaining a mean arterial pressure of more than 65, systolic blood pressure of more than 100 is another important aspect where we can prevent it. And third and most common, you already said that ACE inhibitors and ARB. Probably we are not stopping ACE inhibitors and ARB at the appropriate time, and probably when things do worsen, then only we stop it. So probably in hospitalized patients, perioperative patients, wherever blood pressure is less than 130 by 80, it is appropriate to stop all nephrotoxic medications if we want to prevent acute kidney injury in hospitals. Thank you very much.
Thank you, Dr. KP.
This one is less toxic. Suppose toxic is said to be there is a less toxic. What is your clinical experience?
So COX-2 and SNID, all of them do cause, because we will have to understand the mechanism, sir. It happens that different arteriole gets dilated by prostaglandins, and any prostaglandin inhibitor would dilate it, and that will lead to decrease in glomerular filtration. Some may decrease less or some may decrease more, but when background is of high risk, if you give an SAID or even COX-2 inhibitor, they are going to inhibit the prostaglandins, and that will ultimately lead to decrease in glomerular filtration pressure, that will lead to decrease in blood flow to the convoluted tubules that occurs after the glomerulus, and that's why that leads to acute tubular necrosis also and glomerular damage also. So it will happen. किससे ज़्यादा होता है, किससे कम होता है? I don't have idea, and I admit, unless there is head-to-head trial for this, nobody can say कि किससे कम होता है, किससे ज़्यादा होता है. But I don't have idea for that. Mechanism लेकिन दोनों में है. अच्छा है कि करेंगे.
Sir, one last question. Most of the dosing participants depend on EFR, but value of EGFR in acute AKI is not very useful. EGFR keep on changing. So any formula that those participants with critical value. Is there any formula?
Let me tell you, since EGFR is based on calculation of creatinine, creatinine always takes time to rise. मान लीजिए आज रिनल शट डाउन हो गया, क्रिएटिनिन 1 था, 2.5 कल होगा, 4.5 परसों होगा, बट द इशू इज दिस कि रिनल शट डाउन आज हो के जेन्युइन जीएफआर तो उसका 5 या 10 हो चुका है आज के डेट में. So for all these conditions, urine output becomes a very important criteria. If urine output is less than 30, probably you have to stop all those drugs which are potentially nephrotoxic, and don't wait for creatinine to rise so that you can estimate EGFR. Thank you, sir.
Thank you, Chandra. It was a nice and exciting discussion. But you have all discussed about the hospitalized patients and serious patients who are compromised with some previous element.
Topic वही था, sir.
That's all right. But I want to say something. Suppose a favorite person comes to you, you are hospitalized. So you are giving paracetamol, some other analgesics sometimes. Because the prostaglandin inhibition is there. They are not going to less. So we are causing more immunity taking. So let us not advise necessarily to say injured patient, febrile patient, any person who is coming to the hospital having pain and all that. So let us avoid that. We have other analysis too. To not not that injectable.
Thank you, sir. So there are three things: MDRD, copper gold, and EPS, EGFR. So is it like that MDRD and copper gold both are same because weight is there with the copper gold. So in Indian patients, whether we should advocate MDRD or copper gold or EPI.
So cockroach profile is considered to have a lot of variations, and MDRD method and EPI, AKI, yeah, that is considered to be better. In our practice, I usually do MDRD method for my evaluation of EGFR in my patients. Thank you. We'll go to the next topic now.
MDRD is not validated for Indian patients. Only CKD EPI is validated for Indian patients. So if you want to calculate EGFR, do CKD EPI. And instead of the creatinine-based EGFR, there are certain conditions, especially in obesity and postmenopausal ladies, where you need to go for a statin-based EGFR, which is instead of this
creatinine-based.
Yeah, instead of creatinine-based. Because that is a statin-based EGFR is also now coming up like a more reliable.
There are certain formulas also which calculates previous EGFR versus what is EGFR after 12 hours, and based on that EGFR is calculated.
Okay, thank you, Dr. KP. Thanks for the nice discussion. Anyway, we'll move to the second system, that is on artificial intelligence versus clinical acumen. Our speaker is Captain TVS Vijay Tilak. Most welcome. Very good. So to introduce GP Captain Dr. TVS Vijay Tilak, he is MD DNP, DM in Medical Oncology, and FIMSA FRCP Glasgow, Professor in Medicine and Medical Oncologist in Command Hospital, Air Force, Bangalore.
Thank you, Chairperson, sir, for the kind words of introduction. At the outset, my gratitude to the ACP India chapter for having given me this opportunity, and especially Dr. Anil Birmani for this invite. And it's an honor to be on this stage to talk to you about a very interesting topic, artificial intelligence versus clinical acumen. A burning topic, I would say, when it comes to all specialties of medicine. The world, as you know, is a big, bold, and new world, and this big, bold, new world is constantly changing. In almost every aspect of this change, there is data. This data in various fields keeps on accumulating. This data is what we call as big data. To analyze this big data, we need algorithms. Human brain cannot assimilate this kind of big data unless we got algorithms of nature, something called artificial intelligence. Now, artificial intelligence is a larger ambit within which is something known as machine learning. Within machine learning is something known as deep learning. And within deep learning is something known as convoluted neural networks. So it's a whole thing which is a complex thing, and it's almost essential in every kind of specialty. We come across this term called VUCA quite often, and often in the military parlance, this is quite used. Something known as volatile, uncertain, complex, and ambiguous kind of a condition. And if you consider our healthcare institutions, I think ICUs probably are one of the most VUCA kind of situations, and hospitals, of course, have very high, complex, and ambiguous cases coming to manage. Same thing in war also. So let's see the whole thing of AI versus clinical acumen through a clinical case. Now, I'm an oncologist. One of our patients, a 54-year-old male, a known case of carcinoma lung, right lower lobe, post-chemotherapy and radiotherapy, is now on immunotherapy for residual disease. Presents with fever and cough of 1 week duration and altered sensorium. Clinically has tachycardia, hypotension, it is not responding to fluids, very nicely explained by my previous speaker. Tachypnea, SATs of 76% requiring ventilation, reduced breath sounds by infrascapular and bilateral crepitations. Diagnosed as septic shock secondary to pneumonia, admitted, ventilated, 2 drug antibiotics to support intraarterial blood pressure monitoring, venous access, feeding tube, urinary catheter. You can imagine how complex the whole scenario is, and I think all of us see these situations in our hospital ICUs. What is the diagnostic accuracy we're looking at? Is it actually pneumonia with septic shock only? What should be the initial antibiotics? Do I add antifungals? Do I give steroids? One of the complications of immunotherapy is autoimmune pneumonitis, very commonly seen. Do I have steroids right now? How do I assess an overall disease state and an overall outcome? How do I consider the relative and the outcome of this patient? Now, when it comes to these kind of decisions, the artificial intelligence can give you some kind of direction, but a whole lot of clinical acumen is required to manage these kind of patients. And how a human thinks versus how a machine is made to learn or think is where the entire difference lies. When it comes to intelligence, it is basically a combination of three words. One is the thought, second is the words, and of course the deed. The whole thing defines intelligence. Now, when an outcome has already occurred in a particular case, for example, there is a finding on an X-ray, or there is a particular histopathology finding on a slide or a tissue biopsy, it is ideal to feed the algorithm into a neural network and make the program learn about what is it like to predict. But what about where the outcome has not yet occurred properly, and which has got variables like which is the best available clinical evidence as on today? What are the patient's values? Patient expectations, and what are the individual clinical expertise? When the outcomes have not yet occurred, feed into an algorithm, the AI kind of takes a back step, and this is where the clinical acumen kind of comes into it. Now, 2022, I don't know how many of you remember this particular match, final between Nadal and Medvedev. At this point of the match, where Medvedev was leading 2 sets to nil, and third set he was leading 3 games to 2 with the fifth game as a 40 love. The AI had a prediction of 92% win for Medvedev, and we all know what happened in the end. It was Nadal who won. So obviously, the AI cannot predict everything. We rely a lot on insight and intuition. Intuition is one of the most important virtues of a clinician. For those who have read the Nobel Prize winner Daniel Kahneman's book, Thinking Fast and Slow, he talks about this particular intuition. You enter a particular ward, you look at a patient, you do not have much of input. You see a patient says he's not looking fine. It comes to you, you do not know what exactly the problem. You get the data, you realize that you've taken the action, and how is the action coming to it is just by the 6th sense. Each machine algorithm or 6th sense is a bit difficult. We all know about this. Red herring do not medical practice. When you have a red herring, you know that you've got to keep it aside and not to include it in your main frame of thinking while making a decision. AI probably would not take this red herring, it will take it as a part of the data and include it into the algorithm and give you an output to act upon. And these kind of red herrings often confuse the whole picture when feeding an artificial intelligence algorithm. So at the most, what is an AI? AI is basically a subset system with a human in the loop where you get the feedback from the loop, you make the iterations and feed the network again and get some more data. But can it replace? Not in every field, some cases it may, but most of the cases it's only assisting. Now, there's a very interesting cycle called the Gartner hype cycle. The new technology, a new innovation which comes into the market, it goes through these 5 phases. There's a technology trigger, there is a need for a particular development, the need is felt, the technology trigger occurs, and suddenly people develop a particular process or a product or something, it goes into some testings, and suddenly there's a peak of inflated expectations. We know that this is going to be the cure-all for this particular problem. And then finally, when more and more data comes, it goes to the trough of disillusionment, the scope of enlightenment, and then finally, somewhere with multiple iterations, we get the plateau of productivity. So right now, probably AI in clinical medicine is the peak of inflated expectations that it will completely replace. We are still yet to see more kind of studies on this. AI to drive the cars is somewhere in the scope of enlightenment. We're getting into there thanks to Elon Musk and his Tesla. Now, when we do clinical decision making, we rely on a lot of data based on randomized controlled trials, based on systematic reviews and meta-analysis, mainly to remove the bias. Now, this bias component is an issue which cannot be removed completely when it comes to artificial intelligence in practice. The studies available since 2014, since AI has been used in medicine, says that bias is a big chunk which is there in this. And it is quite intuitive to think that when we are practicing medicine and we want to practice medicine for the future, we are relying on the evidence today to make a decision for the future. Isn't it counterintuitive thing that we are feeding the data of yesterday and yesteryears to the machine to make a prediction for the future? So there are these kind of problems, and these problems are what we know as time series problems. When your data is limited and you have to forecast the future, you do not have the capability to see which way it would go into. And the artificial intelligence suffers from this forecasting, the time series problem for forecast. Now, there's a very nice wisdom hierarchy known as DIKW, that is data, information, knowledge, and wisdom. Here it says that data, you collect the entire data, numbers, figures, whatever it is, you make it into separate categories and you have some information about the data. You then see how to get a proper knowledge out of this data. All this can be done by various processes, but what to do with the data is where the wisdom lies. In almost every field, business, medical medicine, this kind of DIKW wisdom hierarchy helps a lot. You can do the data collection, the data curating, the data cleaning, etc. Get an information out of it by using the artificial intelligence methods. You can actually construct the knowledge component part of it, understand and explain why what is happening, whatever data is there and the correlation why it's happening. But what to do with it in the future probably is where there is a small difference between human wisdom versus artificial intelligence. Now this is the Malaysian airport where there is automatic walk-in system. We are now finding with DigiYatra in India also. But every 10 such machines, there is a human interface which is behind, which is trying to control this particular automated system. So AI is there, but not completely into the entire ambit. IBM Watson, we all heard about it. As an oncologist, we had a big expectation from IBM Watson, where he could feed the data and it will tell you which chemotherapy regime to use, what would be the prognosis, what would be the output. And after nearly, I think, 4.5 years of trials and $62 billion, finally IBM has withdrawn this into back into its company. Now, like I said, we rely a lot on data, which is without bias. So there was systematic review in AI and clinical medicine. There is only one systematic review which I could lay my hands upon. Nearly 8,300 studies, of which full text articles assessed by eligibility were 236. Only 91 ultimately included the study, of which none could be taken up for meta-analysis. They could only do a systematic review. Let's see a couple of examples they gave. 350 children at an ophthalmology center in China had a comparison between the clinician and the AI machine on the accuracy of diagnosis, the treatment recommendation. Both of these, the humans scored more than the AI, but only the time to diagnosis, the AI was faster. But in gastroenterology, they found that the rate of picking up the polyps as well as identifying hyperplastic polyps was much more by the AI algorithm than by the gastroenterologist. So the principal finding of this systematic review was, of the 10 studies, there were of the 86 studies they studied, only 10 were randomized controlled trials. Among the non-randomized studies, only 9 were prospective. The limited availability of data sets to code and difficult to assess reproducibility. And humans in the comparative group were quite low, only 4 that were there. And this kind of over-promising language in most of the studies saying that AI can replace, AI can do this, kind of makes you vulnerable to misinterpretation of data and thinking that yes, AI is actually there to replace the clinical. When it comes to empathy and emotional intelligence, we know that there is no way you can teach a deep neural network about this part as well as about the strategic thinking which is required in these particular cases. Now, when there is a particular car accident of a auto-driven car, AI-driven car, who's responsible? Is the owner responsible? Because the car belongs to him, but he was not driving it. So AI was driving the car. Is the manufacturer responsible? Because he manufactured the car. So there are a lot of problems of this in AI. And the judicial pragma of AI in legal practice in clinical medicine is a big question mark yet to be solved. Coming back to the VUCA environment, the human brain in its predictive processes uses all these items: the experience, the intuition, the values, the ethics, the expectations, thoughts, judgment, as well as the emotional intelligence when it comes to taking a particular decision for a particular patient. When it comes to AI processing in the same VUCA environment, yes, it can handle big complex data. by using its analytics. It uses a brute force approach and a decision tree in uncertain places, can be correct at times, may not be always. When it comes to volatility, it lacks flexibility, cannot be very flexible in volatile situations. And of course, when the situations are very ambiguous, there is inappropriate functioning of these deep neural networks. It does not know which way to go actually. So VUCA has now been replaced by something known as BANI. BANI is nothing but brittle, anxious, non-linear, and incomprehensible. So for brittleness, to handle this, you require capacity and resilience. For anxiety, it asks for empathy and mindfulness. For non-linearity, you need context and adaptivity. And for incomprehensible demands, you need transparency in intuition. Where do you fit all this into an AI program to completely replace the clinical acumen? So my final thing, when you have a clinical scenario of this nature, which is a complex case in the ICU, you need data analysis. You need an AI support or an algorithm to guide you to analyze the data. But to take the final decision, it has to be the human brain, and the interface between the human and the machine is probably the best way we can take our decisions. What is now known as the Journal of Cardiology recently published an article, they call it collaborative intelligence, where the machine intelligence plus the human intelligence put together helps us in taking decisions for our patients. With this, I finish my talk a bit early.
Thank you, Dr. Tila, and again thank you for finishing it before time. I will be relying on my on my that cannot make it, but you open for discussion.
Yes, ma'am.
That was a fascinating presentation. My question is this. AI is already being used extensively all over the world in decision making. Do you have any information in India? Where do we stand legally when we use AI and make a mistake? And where do we stand when we don't use AI and make a mistake? Is there any Indian
Ma'am, the guidelines are still evolving. There is no India-specific guidelines as such. Even worldwide, they are finding it difficult to lay their hands on completely AI-generated information. So they use the AI, they get the information, but there's always a human loop to convey it to the patient.
That actually brings me to my second question. Now, since there's a human loop, do you foresee a time when there's going to be a plateau? I mean, if we keep the human loop increases the artificial intelligence, at some point it's going to plateau, right? The artificial intelligence, how can it be smarter than the human who's part of the loop?
So as it comes to data curating and data analysis is where probably AI will help you in managing it quickly, managing it in a way, probably giving us options which we may not be able to think immediately. We'll give you 3 extra options than what you are thinking. But to ultimately take the decision, I think the human brain is still there. Even in diagnostics, where they're saying that AI might replace pathologists or AI might replace radiologists, I think that day is very, very far away. But very important questions. Thank you.
Excellent talk, Dr. Tiller. I just want to make a comment. We are still using AI even now, maybe the smartphones and the various machines that we are using. But as far as the medical field is concerned, we are using AI also in the medical field, in radiology and all that. It is basically, it should be used more as a clinical assistant. To recruit, to keep data, to analyze data, and then from there, when your data is analyzed, it can be used to take decisions by the human person himself, because the machine cannot take a decision. Very decision has to be taken by you. Very so, as you very rightly said, it is collaborative intelligence that is ultimately going to play in the future.
Very true. Like the AI systems in practice right now, they are products, like we have the robotic surgeries, where the surgeon is just doing a little bit of thinking, but most of the thing is done by the thing. Or that can be the programs which we commonly keep using. But yes, the human has to be in the loops.
Thank you, Dr. Tila. Thank you, everybody. There is a little change in the hospital to ambulatory care and coordination and transition has been omitted. And it has been substituted by another topic, is diabetes and inflammatory disease, biomarker tell the story. Speaker will be Dr. Anju Maheshwari. You know her very well. Is that there? Yeah.
you. Thank you, Chairperson, for the kind introduction. And this is also a thing which is mandatory to do to organize any conference. This is again a sponsor talk. There is a disclaimer before starting this. Is diabetes an inflammatory disease? Biomarkers tell the story. What does the biomarkers tell the story, and whenever they are required? When this story is required to be told. At multiple stages data, like whenever we want to early detection of the disease, whenever we want to predict the occurrence of the disease. The biggest issue is that how can we really predict the occurrence of diabetes kind of a disease which starts 15 years before like the actual diagnosis. Whenever we diagnose the diabetes, the complications of the diabetes and its inception 15 years before starts. What biomarkers can be there which can really predict the occurrence of that? How can it be looked forward that what are the risk stratification and how to select the therapy? Again, this is $1 million question. So what is the historical perspective? What is in the past? What we have already reached to the conclusion? A lot of observational studies that provide the first evidence for the possible association between inflammation and diabetes. Over a century ago, the administration of the high dose of the sodium salicylate led to decreased glycosuria in people with a suspected or definite diagnosis of diabetes. Later studies on the role of inflammation revealed that this hypoglycemic action was related to the inhibition of serine kinase I-kappa-B kinase beta, IKK beta, which correlates with the post-receptor action. A landmark study to correlate inflammation with diabetes was conducted in animals by Posthumously and its associates in 1993, and it revealed that role of human necrosis factors, TNF-alpha, in obesity and particularly in IR and diabetes. So there is an epidemiological association with obesity and type 2 diabetes, which has really made when circulating concentration of markers and mediators of the inflammation and accused with reactants including fibrinogen, C-reactive protein, interleukin-6, plasminogen activator, inhibitor 1, and sialic acid, and of course the WBC have been shown to be elevated in these conditions. Can these conditions really be characterized by these inflammatory markers, and can they really be a predictive value in cardiometabolic disorder? There has been an observation in which the chronic inflammation has been supposed to be the initiating factor for these metabolic disorders. There has been a molecular mechanism behind those cardiometabolic disorders, which includes all these biomarkers, all those inflammatory markers which has just discussed, they activate the endosomal NADPH and reactive oxygen species are increased, free radicals are increased, causing the inflammation, ultimately ending up with the atherosclerosis, diabetes, and metabolic syndrome. What I suggest and what I said in the beginning of my talk that diabetes is diagnosed today, but its complications start 15 years before in the form of the endothelial dysfunction. And that endothelial dysfunction actually brings the atherosclerosis that causes the heart attack and acute coronary syndrome even before the occurrence of type 2 diabetes, even before the diagnosis of the type 2 diabetes. So pathophysiology of the metabolic syndrome, which is associated with this low-grade systemic inflammation, which ending up with metabolic syndrome and cardiovascular disorder. There are a lot of inflammatory signals which are not only related to the type 2 diabetes, but also type 1 diabetes is also associated with inflammation and ending up with the dreaded complication. Let's talk about the inflammation in type 2 diabetes. It contributes to insulin resistance, beta cell dysfunction, and onset of type 2 diabetes in multiple manners. There are the set mechanism which has been explained multiple times in a multiple way, which ends up that insulin insufficiency and insulin resistance both are associated with inflammatory markers and causing the occurrence of type 2 diabetes. So inflammation and microvascular complications of diabetes are being seen when they are ending up with the nephropathy, retinopathy, and neuropathy. And this pathway for hyperglycemia to diabetic peripheral neuropathy has also been understood well with the presence of inflammatory markers. For type 2 diabetes, which is supposed to be an inflammatory disease leading to insulin resistance and beta cell dysfunction, there are certain international evidences which are supporting these inflammatory markers which are behind the origin of type 2 diabetes. What are those markers? So once we talk these markers, these markers must be understood in the light of the fact that diabetic subjects have shown 2 to 4-fold increased risk of the cardiovascular disease than if there is no diabetes. Can be prevented if detected early at pre-diabetes stage. Progression of the diabetes not only causing the hyperglycemia, it also increases the risk of macrovascular, microvascular complications. So there are different mechanisms which has been played in the previous slide, which are ending up with the inflammation and causing that inflammation, association of this inflammation with the complications of the diabetes, may it be neuropathy, nephropathy, retinopathy. These mechanisms alter different signaling molecules in blood and other body tissues. So different kinds of the biomarkers like biomessenger RNA, protein, metabolites, cytokines, and adipokines can be used together to detect at different stages of the disease, and identification of early biomarkers for non-communicable chronic disease such as diabetes is very important for finding age efficacy strategy. Pre-diabetes and insulin resistance are characterized by marked inflammatory biochemical markers like acute reactants and inflammatory cytokines are elevated on the onset of diabetes and may further increase with disease progression. These markers such as heat-reactive protein, WBC, and phytogen have been investigated as potential predictors for the development of diabetes, like in many communities. So potential markers which should be considered evidence of the chronic low-grade inflammation of the WBC count, serum cytokine markers like interleukin-6, TNF-alpha, interleukin-10, acute phase reactions like CRP, serum myoglobin protein, phytogen, immune cell markers like CD8 plus B cells and CD4 T cells count and CD19 P cells. But the basic and simple which can easily be done anywhere to know about that WBC count and CRP level, especially if we prefer the highly sensitive CRP level. If these two are there, then definitely we can think about some information. These are the basic tests for the information, and later on we can go for the other markers. Prospective evidence linking inflammatory markers to diabetes development are number of studies which have been done in different parts at different times. Many studies were more than 4 years or around 5 years, more than 5 years or so. And almost all have established that baseline inflammatory markers which have been measured, either CRP, interleukin-6, phytogen, adiponectin, they have been found to be increasing after the period of 12, 24 weeks. Adiponectin, TNF-alpha, and inflammatory cytokines and the risk of hyperglycemia has been also analyzed in systematic reviews and meta-analysis in which we could see that 19 studies meta-analysis in which we could see that association and writing of CRP, TNF-alpha, and reduction in metabolic results. So this is highly sensitive CRP, which is associated with the cardiovascular markers and diabetes, is also being proven with the studies in which number of patients which had the cardiovascular events in subgroup were found to be having raised CRP level. CD8 protein is an independent predictor of the risk for development of diabetes in the west of Scotland or on prevention study, in which what we could see that higher quintile, in which the CRP was more than 4.18, has been associated with more than 3-fold risk of developing diabetes. Mediators of the inflammation and progression of normal to type diabetes in Indians have been established as CRP and IL-6 in number of studies. Relationship between WBC, CRP, and metabolic syndrome has also been well established, and it was found in patients with metabolic syndrome, C-reactive protein, and white blood cells found to be increased. And high white blood cell count is associated with worsening of the insulin sensitivity, or you can say increasing insulin resistance, and predicts the development of type 2 diabetes. Immunoglobulin free light chain apparently as inflammatory biomarkers of diabetes are being suggested maybe arising out of obesity or because of some virus-induced change in the system of in the chromosomal system, hyperglycemia is causing raised immunoglobulin free light chain. American Association of Clinical Endocrinologists and American College of Endocrinology both has issued the guidelines for the management of dyslipidemia and prevention of cardiovascular disease, and it has been seen in major associated cardiovascular disease risk factors assessment in diabetes and metabolic disorder that non-traditional risk factors like inflammatory markers, HSCRP, and LPPA2 were found to be associated with the mechanism. Inflammatory markers and their relation to metabolic syndrome and type 2 diabetes have been established in multiple ways, where you can see a lot of cytokines which are found to be raised, interleukin 6, interleukin 1b, interferon, TNF-alpha, hepatokines like fetulin, A, idipokines, chimeric found to be raised because of cellular something like food, anything comes with diabetes mellitus and metabolic syndrome. Characteristics of biomarkers of the pre-diabetes, diabetes, and associated complications. Here we can see that CRP, interleukin 6, and WBC, which have been established as biomarkers for not only diabetes but also pre-diabetes as well as for the complications of diabetes. Wherever we can see any biomarkers going out of the range in a patient, we can predict the adverse outcome which may be in the future. Characteristics of the biomarkers for pre-diabetes and diabetes and other complications are also established with the fibrinogen level, PAI1, interleukin 18, and interleukin IL. This is an inflammatory marker when interleukin 1 pathway reduced by glucose and free fatty acid during overtraining. In these, interleukin 18 correlated to production from diabetes, pre-diabetes to diabetes, and it has been associated with an increase in insulin resistance, temporary increasing beta cell function, and elevated in pre-diabetes and diabetes. So there are the role of hydroxychloroquine also in management of diabetes. Thank you very much for your time.
Thank you very much for finishing much before time. So now we will land in biochemistry and immunology for treating diabetes mellitus. Actually, is a complex phenomenon. What we consider the complications of diabetes mellitus, actually that occurs before hypertension. Now it is open for discussion.
Except Robert, some don't have this particular stage. Biomarkers will help in any way. Can we do these biomarkers and then expect that we will be preventing or delaying the onset of diabetes? Is it possible or?
Obviously, in the interest of getting the biomarkers in any diseases that we can prevent them. If we can't prevent them, what is the use of doing the test and doing about the very importantly, it is to be understood and it has been seen in multiple studies, and people, those who are found to be raised with biomarkers, they can reduce their level by doing the vigorous exercise, by doing a vigorous lifestyle modification, and it has been seen that this is inflammatory marker has become. So again, all the methods which are meant for reducing the insulin resistance, they are also working to reducing these biomarkers. Even in our day-to-day practice, we see that some of the patients, when they are in their bad diabetes or bad hyperglycemia, if you get checked their CRP level, if you get checked their WBC, if you get checked their iron level, you will be finding all very high. The patient who will be controlled diabetes, they may not be finding it so much of that. but there are limitations. The people who are having the controlled diabetes, still they are having this kind of elevation in their biomarker. It is a sign that patient is heading towards the complication or worsening of the complications. So we should be alert. This is a sign of alert at this time. Whether they may be the tool of prevention or not, this is yet to be studied. And today we have presented the next all the IR study. In this IR study, we have seen that people who have been given the vitamin D supplementation, those who are having a deficiency, not everyone, those who are having a significant deficiency, they have been given the supplementation. Nothing has happened to those who are having the normal MIA. Only those who are having the high MIA, only those who are having the high insulin resistance, they could be, they were seen to reducing their MIA very significantly. So this is the impact that things are changing where the inflammation is high. And if the inflammation is not high, then probably you are not on the list.
Any role of anti-inflammatory drugs?
Yes, I just mentioned hydroxychloroquine is an anti-inflammatory drug which has been studied abroad for this purpose, and this is a medication which works reducing the inflammation together with reducing the glucose level, and it has been recommended, it has been approved by the TCI to be used in India, the diabetes patients who are not controlled on the sulfonylurea metformin combination. Long back it has been approved that maybe we can say that those who are not controlled on the two drug, those who are having the high level of the inflammatory marker, those who are associated with the joint problem, they all can be a candidate of the drug.
Thank you, very nice job, very nice. You will add it back. So the session is over, I think. And this is the time for felicitation.
Thank you, Dr. Such a very session. I would like to know all about Dr. Ajay to facilitate our chairperson, Dr. Sahuda and Dr. Raman, and facilitate them with the movement session to come forward.
ସେଟା ରଖିଛନ୍ତି ଦରକାର ଅଛି ସେପଟେ ମୋ ପାଖରେ ନାହିଁ ସେପଟେ ଏଇଠି ଦେଖିଛନ୍ତି। আমি কি সামলাইছি সেলটা করছেন ସେ ମୋ ପାଖେ ଆସିକି କରିଥିଲେ ତ ନାଇଁ ମୋ ପାଖେ ନାହିଁ ସେପଟେ ଆଉ ତମେ କୋଉଠି ଏ ମେମୋରି ଆଉ 46 ମିନିଟ୍ ମେମୋରି ଗୋଟେ ଅଛି 16 ନା କ'ଣ ଅଛି ପକେଇ ଦେଇ ଗଳୁଛି ହଉ
Continuing the jack of all trades hospitalist, I would now like to call upon Dr. Namita Mohammed, Dr. Samir Sahu, and Dr. Chandan Lal. Please chair the next session.
Good evening. So we start the next session, and there has been some change in the program. Now now we have a topic unmasking the faces. This will be presented by Dr. Mukhya Prana Prabhu. So he will be the first speaker of the session. So I invite Dr. Mukhya Prana Prabhu to start his deliberation.
So when the topic was given to me, I was wondering what is this topic? Unmasking of faces. Reading from page 25 where I come. Regarding stop, no financial disclosure, no architecture interest. These are all my pages which I have taken photograph, and some of them are given by my wife, the dermatologist, and some of them from the oral medicine surgeon. So my outline of my talk is what is the clinical medicine expression. What is the clinical example? Previously, my speaker has already spoken on artificial intelligence. We are all worrying whether artificial intelligence will take over. But we have finally concluded that clinical doctor is required to show the diagnosis and treat the patient. So I will be dealing what are the various kinds of patients in various disorders, including genetic, neurological, endocrine, hematological, chronic diseases, and computer diseases, and what are the causes. So we have just come out of the COVID pandemic. All the patients' faces were masked, all the doctors were masked, and Dr. Fassi was leading the campaign. Face mask protects. So just now we have come out of that, now faces are being removed, but again I want to remember this doctor, Dr. Lee from China, who was the first person identified the COVID pandemic. He was an ophthalmologist before Chinese government announced. He told that mask is required, there is a pandemic going on. He was treating the glaucoma patient. Unfortunately, he was one of the first victims of COVID. So I want to remember these two people. First, he told the importance of mask. He told that initially COVID pandemic is coming. So what is face in the clinical medicine? Appearance of person's face checks indicators of the condition or disease. So it may be genetic enough like Down syndrome, where mongoloid is seen. Endocrine disease, pushing the classical phase. Hypothyroidism, yesterday, patient has a classical rash. You can make a diagnosis looking at the patient. Hereditary disease, infectious, parvovirus, flap cheek syndrome, fifth-day disease, Hansen's disease, that is a reoccurring disease. And some other thalassemia, you can make diagnosis for pernicious anemia. So what I think is doing is that what are some of the cases which I have seen. First, let us remember the father of medicine, Hippocrates. He did Hippocratic cases. You will be seeing this in the day-to-day patient who are daily. It is not described with respect to perforation parameters. Patient has a hollow eye, collapsed temple, brown, black, green, red-colored face, rapid breathing pulse, tongue is dry, shriveled, peripheral is poor. You must have seen that with each undergraduate, peripheral patient will be lying down without any movement, face will be like this. So Hippocratic face was described in the BC 463 you describe all the diseases. But let us remember the father of modern medicine. He said, observe, record, tabulate, communicate, use of your five senses, learn to see the patient's condition, learn to look at the patient, that is important of clinical medicine, and learn to hear, learn to feel, learn to smell, and know that by practice alone you can become an expert. It's your use all senses. Artificial intelligence is very additional thing in India, which you have to use it properly in your future destiny, but the most important is our senses. This is not medium master looking at the patient, ascertaining, coming close to the patient and observing what is told. Variability is not like, and no two faces are same, and no two bodies are alike, and no two individuals react alike, behave alike under the abnormal conditions. So that is one of the disease. So each patient is different, each patient is different, each patient behaves differently. So we need clinical science. So there are so many phases that can be described. I will not tell them able to get it. Identified basis, involved myocardial infarction, amyloid basis, blood basis, ovine basis called Crohn's syndrome, chipmunk phase, malaprostome in the childhood thalassemia, fourth basis of involved metabolism, hereditary basis, Williams syndrome, flat basis or mongoloid basis, Down syndrome, frog-leg basis, inflammatory disease, COPD, gargoyle basis, Hunter syndrome, originator basis, nephropathy, Hippocratic basis record, Leonin basis leprosy, Mast-like basis Parkinson's disease, mitral basis we have seen a lot of things in stenosis patient, but I have not seen classical electrolytic basis with the basis distinct. Master basis is hydrocephalus, monkey basis is myopathy, moon basis is Cushing, mouse basis is chronic kidney disease, Pleurer basis is polycythemia, hereditary basis is vegetative disease, Snappy basis is myasthenia, carpet basis is cyst. This is not what I described from A to Z. What I will try to cover, what has in my practice, which I have not photographed on this thing. I can pick up science. I have taken a photograph with the patient information. This is really not into the OE. Like this. She is not doing properly. They have brought her, she doesn't talk, she doesn't this thing. So, it will take a minute. So she said she was not even talking, she was not even sitting. She was Parkinson's. Expressionless, no facial movement, no slightly open, and no differential diagnosis of considered depression. So I thought this is depression. Then I texted her, she had a copy of the identity, tremors, what wrote it. It is a case of Parkinson's disease. And masking of this, first thing that comes to mind is that Parkinson's disease, which you look at patient pain, you can anytime get a diagnosis. This patient is not a patient. Doctor, I made a doctor come to me, asking them to take consultation from me to cure his disease. When I looked at the face was looking like this, he told that there was a weakness, baldness of the face. He didn't allow me to take a photograph. I have taken a photograph. It is a natural face. The patient, he was an Ayurvedic doctor, but he told, you will use my photograph for the teaching purpose. I don't want to give you. Similar ways, from the internet. So, frontal quality, ptosis, cataract, with the muscle meeting and nerve. Here I am taking another 24-year-old Ayurvedic doctor which I had in my clinic. This is the bilateral ptosis cause disease, unilateral and lateral palsy, Parkinson's syndrome, bilateral myasthenia gravis. In ICU, due to neurotoxic state by and arterial vascular. But say, physically, she has got ptosis. She has got right tube. She has got not fitting in the one side. This is the case of lateral resistance. So, your relaxed wall, it's a patient has come with dysphagia, but actually ataxia. So, she had a lateral resistance. So, patient palsy, there is a lot of differential types of patient palsy. I did not know unilateral, bilateral. Infections can be there, autoimmune diseases can be there, neoplasm, infiltration, metabolic disease, toxic, genetic. There are so many differential diagnoses. When you look at the patient, you can make a diagnosis of Bell's palsy, but it will be very difficult to diagnose bilateral facial palsy. So this lady has got a diagnosis written on her face. She came with a mask. When she removed the mask, the diagnosis is obvious. It's a case of SA. So she had a butterfly shaped rash. Last lupus is called Latin word wound. Initially thought to be due to wound bite, distinctive rash. Once full blown around this shaped rash, healed from inside out, leaving a bite-like imprint. So this is another girl who had come with this. So everybody can be, this is a corrective tissue disease. Yesterday overlaps. She has got a vitiligo patch or hyperpigmentation, joint involvement, rash, and DNA was positive, DSDNA was positive. Rheumatoid factor was positive, UNRNP positive, and vitamin B12 deficiency also she had. This is a boy which has got a linear morphia, sclerosis characterized. That means after a protective childhood morphia is occurs in the present like this. This is another lady who has got, anybody can guess the diagnosis? Scleroderma. Okay, Rett syndrome. Fish-like mouth, loss of expression, lines on the face, giving a mask-like appearance. Fish mouth with beak, nose, calcinosensitivities, Reynolds, esophageal dysfunction, steroidectomy. All those things you can see. This is a classical case of Rett syndrome. She developed tuberculosis also. We have to treat for her. This is another lady with the same thing. Again, little bit difficult. Face is fish mouth and also rash. So this is another very difficult case. He came with a multiple joint pain and these lesions over the face. So initially I thought it's a straightforward gout or something, gout or sarcoidosis. But when I did the biopsy, it is a rare disease, what is called rosacea Overman syndrome, sinus histiocytosis with massive lymphadenopathy. She didn't have lymphadenopathy, she had only cutaneous and joint lymphadenopathy. So she is under treatment, she is doing well. This, anybody can guess, it's a classical case of Stevens-Johnson syndrome. She was taking antibiotic, she developed this with a rash starting in the face and thorax. The scalp is typically spared, atypical target lesions can occur, but you have to look at the lip to make a diagnosis of Stevens-Johnson syndrome. This again has got a classical. This person is 140 kg weight, face is round. Anybody can guess? Who faces? Plethoric, buffalo hump, obesity, yeah, Cushing syndrome. Okay, Cushing this. It's a classical picture which he has developed a fracture of the thing. So this lady, she's a staff nurse. She came in a hypotension, hypoglycemia, and also she was having acute adrenal crisis. Okay, father without any and actually another surprising thing that she had a dengue also was positive. I am not sure whether dengue can cause one incompetence when she came. She is a staff nurse. So this case is classical. Looking at the face, it's a Graves' disease. So along with that, patient had a classical dermatosis. What is called? Okay, this is another patient, hypothyroid, classical face. You can look at the patient and talk to the patient in the phone. You can make a diagnosis. This lady is again, she has got a vitiligo patch, anemic, and also it's a megaloblastic anemia. So pernicious anemia, but we don't do the screening test, but it's based on antibodies to make the diagnosis. These are the three classical features which we could diagnose looking at the face: jaundice, anemia, and the pallor. It's a vitamin B12 deficiency. Many times it may be diagnosed as a jaundice, and some people say why jaundice. They will go to various doctors, but it's due to ineffective erythropoiesis. They will have mild jaundice and classical B12 deficiency, pigmentation, and also treatment completely. So this patient is a plethoric. The diagnosis is polycythemia vera. So patient will have a multi-complexion, plethoric patients, aquagenic neurosis symptom, and also bleeding and thrombosis both can occur. So this is another unusual case. She came with sepsis, recovered and went with bone marrow, pancytopenia initially. Then she had multiple lesions over the face. It was a deposit of leukemia underlying pre-bleed survey published in Australian Journal of Dermatology. So this man really came with a multiple degree of the hyperplastic gums. So it was due to acute thyroid leukemia. So this is another case which is learning face. It's not a classical one. So patient had multiple lesions over the face, hypostatic patches, and also diagnosis was evident. Again, differential diagnosis can be anything, but this is a classical leonine face, lion-like face given in any case. This is another way looking at the patient, you can make a diagnosis. Severe pain in the trigeminal mandibular division, there is a vesicular eruption, it's a herpes zoster. So this lady is an unfortunately young lady with a smiling face. She came, she was breathless. She was in ARDS, but her face, the diagnosis was written. You can see that this is the S scar. It was a scrub type. Unfortunately, with all the diagnosis, we could not save it. So she had a diagnosis written on her face. We could make the diagnosis treating. This is very common season. We get a lot of cases of acute febrile illness, jaundice and subconjunctival hemorrhage. Strongly we suspect leptospirosis. Classical leptospirosis with multi-organ jaundice is evident, subconjunctival hemorrhage is evident. So this is another dengue fever. Patient is plethoric, presenting with subconjunctival hemorrhage and facial puffiness. So this is before COVID era. So classical black fungus, very disturbing picture. So extensive involvement of the face, sinuses. This is another lady. This is a cavernous sinus thrombosis. If you pick up early, patient can be saved because it's a very dangerous condition. Presents with pain, ophthalmoplegia, headache, and periorbital swelling. So early diagnosis is crucial to save this patient. This is a cavernous sinus thrombosis. So this is another case which was given by my friend from the maxillofacial surgery. This is, you can see the right side of the face is too tall, overtly flat, small cheeks, and a big nose appearance. This is a Crohn's syndrome. So which we don't see it in the childhood. He has come in adulthood with this symptom for any curative illness. So this is a classical picture which Crohn's syndrome if we see it in a child. Next is we know all of us, slap cheek syndrome, fifth day disease, usually seen in parvovirus in children, where adults may present as an aplastic anemia. So this case is a lady who was diagnosed to be hypertensive, started on a treatment, she came with this. Initially, what do you think? Her face has got a space peripheral persistence and lymphedema she had. It was a ARV angiodiuretic edema. So this person, jaundice, bleeding, and paralytic swelling is alcoholic. It is a classical case of chronic liver disease. So this, all of us will be seeing day to day, but not a classical picture. Chronic kidney disease patient, pallor, dryness of mouth, breath, and all those things. This is a port-vein stain, young boy, repeated seizures, admitted with pneumonia, and a port-vein stain, and refractory seizure, secondary to Stooge-Weber syndrome. So this we all of us know when they come with their face diagnosis is written. This is hyperlipidemia which we can be treated aggressively to prevent myocardial infarction. This is one of my patients, coarse nose, flat teeth, and he had a murmur. He was a case of Hunter syndrome. Unfortunately, after 4 years of treatment, he succumbed to the illness. So these are various places which are given in a genetic diseases. I am not going to go to Down syndrome, all of us know. Marasmus, I have already told, hydrocephalus, cretinism, we know. So, coming to the importance of clinical medicine, I would like to end quote with Robert Hutchison. From integrative to red cell alone, from too much gene for the new artificial intelligence system, there is a report that one young boy visited 17 doctors before artificial intelligence made the diagnosis Leonard Card syndrome. Yes, we need to talk to the patient, we have to diagnose the patient. So, going for artificial intelligence, what is more from putting knowledge before wisdom, science before art, and cleverness before common sense, from treating patients as cases, and from making the cure of the disease more previous than endurance of the same. Lord, deliver us. This is Hutchison's prayer, which all of us when we join medicine, they tell, please read Hutchison. Probably present state students are neither are reading Hutchison, they are only going for Googling or Wikipedia. So, this is my take home point. Face looking at the patient. When the patient walks into the OPD or sitting outside, if you look at the patient, you can make some diagnosis. Patient will be anxious, but there will be some clue to your diagnosis. Bedside examination is the most important. Artificial intelligence is there. It's required to be an additional feature. History taking and bedside examination is a strong foundation for a patient. The daily part of clinical medicine has to be reviewed. So these are my references. Thank you for the patient listening. Yeah.
Thank you. The presentation was very good. The pictures were really so illustrative. And clinical medicine should not die. And we should feel, we should see the patient, we should feel the patients, we should hear the patient as you said rightly. So any questions from the audience?
Because this topic was a little bit confusing for me. Initially, I thought after COVID era, what is the rule? So, what is important during COVID? You are not seeing the patient faces. So, when you come back, now we are seeing the faces and the clinical examination patient. Students, residents have forgotten to take it. How to examine, many people have forgotten. So, now we have to go back to the basics of clinical medicine. That's what is my message.
Exactly. Any questions? So he has illustrated everything. So there are no doubts and no questions from the audience.
The sir asked me, I've seen it, but I have not taken the picture. So because there are so many things which is very important. What is common things, what I have seen, I have taken them.
Okay, thank you, sir. So the next speaker would be Dr. Nandini Chatterjee, and she will be speaking on peripheral blood smear used to diagnosis. Welcome, ma'am.
Good evening, everybody. My topic of discussion today is peripheral blood smear clues to diagnosis. Peripheral blood smear is an easily available, cheap, simple procedure, but it is often diagnostic of a disease or gives us directions for the next investigation to be chosen, and sometimes it helps us to cross-check automated analyzer report. So despite the fact that many sophisticated investigations are at our disposal these days, we cannot ignore the importance of peripheral blood smear examination. So let us begin with a very common case scenario of a 35-year-old lady who comes with exertional palpitation and fatigue, and she has a history of menorrhagia for the last few months, and on examination you find mild pallor. She comes with a report which shows a low hemoglobin and RBC count with an ESR on the higher side. So the peripheral blood smear, as the audience can easily guess, shows RBCs which are of various shapes and sizes, and there is a marked central pallor. Such a peripheral blood smear report tells us that what we can expect in the complete blood counts, and indeed it shows a very low mean corpuscular volume and a low PCV. In our country or in our setup, when we get such a picture, we know what investigation we should do first in this case, and that is a iron profile. And the diagnosis is confirmed, and you go for the diagnosis of iron deficiency anemia. I illustrated this case because, firstly, this is one of the commonest problems faced by the physicians when the patients come to us. And next is that it illustrates how a simple blood smear will tell you that not to go for a whole barrage of investigations, but pinpoint for a particular one. So when will we ask for a peripheral blood smear? If you clinically suspect some disease, you get organomegaly, pallor, jaundice, or suspect organ failure. If there is unexplained cytopenias or leukocytosis found in your automated analyzer report, if there are clues to bacterial sepsis, or there is oozing from the vascular ports or ecchymosis, when your clinical examination makes you think of various hematological malignancies, or you are suspecting some kind of nutritional anemia, you ask for a peripheral blood smear. The success of this simple investigation, however, depends upon making a accurate smear preparation and also on the expertise of your pathologist. Also to be ensured is the fact that the samples should not be delayed more than 2 hours after blood collection. This is very important because any delay will lead to a degeneration of cells and formation of platelet aggregates. When platelet aggregates form, then you can get a phenomenon called the pseudo-thrombocytopenia. So coming back to our initial premise is that we have automated analyzers and they give a lot of information about the patient's peripheral blood, but is it enough? I would like to draw your attention to certain fallacies in the automated analyzer report. In conditions where the patients are having a high triglyceride count, there is hemolysis or presence of agglutinins or an excessive amount of bilirubin in the blood, you can have erroneous reports. If the patient is suffering from some hematologic malignancies like paraproteinemias or leukemias, there also can be errors and you can get either a higher or lower hemoglobin level than what is to be accurate. There can be abnormal leukocytosis or leukopenia, errors in the MCV, hematocrit or MCAC, and sometimes low platelet counts, which are fallacious. In those cases, you need to cross-check by the peripheral smear examination. So what are the cellular components that are to be examined? They are the RBCs, the WBCs and platelets, and of course a group of special cells. These special cells, if they are recognized, they can immediately point to some particular diagnosis. For the RBCs, you check the size, shape, color, inclusions and aberrations. Microcytosis, as demonstrated, can be found in iron deficiencies, but also in cases of thalassaemic patients, sideroblastic anemia and lead poisoning, you can get microcytic anemia, and you have to correlate the clinical findings and then only order your next investigation. Macrocytes, which are RBCs larger than the normal, can be either oval or round. Oval macrocytosis is a feature of megaloblastic anemias which occur due to a deficiency of folate or cobalamin. On the other hand, round microcytes can indicate alcoholic liver disease. A wide variation in the size and shapes of the RBCs is called anisocoikilocytosis, and that is found in either iron deficiency anemia or dimorphic anemias. So here are some photographs. The first one, it shows the macrocytes. However, significant is another cell that is visible. It is a neutrophil with a nucleus which is hypersegmented. So if such a hypersegmented neutrophil is found in the peripheral blood smear, it is almost diagnostic of a case of megaloblastic anemia. The second picture is that of a microcytic anemia, where the RBC size is smaller than the nucleus of a small lymphocyte. The color of red cells is also important. It reflects hemoglobin content. Decreased hemoglobination is found as we know in iron deficiency, but there can be also a condition called hyperachromia, which is found in spherocytic RBCs. Here are the names of certain special cells as I was mentioning, like the spherocytes, the stomatocytes, target cells, teardrop cells, spark cells, bar cells, and sickle cells. I will come to the photographs one by one. So the figure A shows the oval shaped RBC, which are called ovulocytes, and this can be an inherited disorder. Okay, the B diagram, it shows target cells, and these cells resemble the bullseye target, and this can be found in various types of hemolytic anemias. The third photograph on the left is sickle cell anemia, where the RBCs have taken the shape of sickles, and on the right we see stomatocytes, where the RBC has in the middle the appearance of a mouth-shaped pallor, which is called a stomatocyte. And if you see this in the peripheral blood smear, you can think that the patient is suffering from some chronic liver disease. Cystocytes. The first figure A on the top left side is showing fragmented RBCs or cystocytes, and they are characteristic of conditions like DIC, thrombotic thrombocytopenic purpura. It is also found in patients of burns or people who have prosthetic heart valves. The figure on the right upper hand is called, those cells are called teardrop cells. They can be found in a condition called myelodysplasia or myelofibrosis. The third photograph shows cells with irregular projections from its membrane, and they are called spur cells. And these spur cells are found in liver disease. So what basically I want to say is that when the examiner, the pathologist, identifies such peculiar cells in the peripheral blood smear, he or she can give us a clue to various disease processes, and that too from a very cheap and easily available investigation such as the peripheral blood smear. There can be certain special inclusions in the cells, like the siderotic granules, which is found in sideroblastic anemias, or these are a special type of myelodysplasias, where there are iron granules inside the RBC. Hinge bodies, Howell-Jolly bodies, these are also important if recognized. Hinge bodies are denatured hemoglobin found in G6PD deficiency, while Howell-Jolly bodies are found in splenectomized persons. This is the picture of a Howell-Jolly body. So let us come to another illustrative case. Here, a 50-year-old male alcoholic person who is hypertensive presents to us with moderate pallor and fetal edema. His CBC report reflects a lower hemoglobin, but also the WBC count as well as the platelet count are on the lower side. This is the picture of his peripheral blood smear. So what is the finding here? The finding is the same which I have shown a few slides before. The cells, the RBCs are larger than normal, but what is very significant is the neutrophil with hypersegmented nuclei, which is visible. So when this is found, then as I said, you will think of a presence of megaloblastic anemia. So your further investigations will be the CBC, where it is reflected that the MCV is much higher than normal. It is a macrocytic appearance. We go for the serum vitamin B12 and the folate acids, which are much lesser than normal. The bone marrow confirms the diagnosis of a megaloblastic picture. Therefore, this person is suffering from a megaloblastic anemia due to folate and B12 deficiencies. Coming from the RBC to the WBC count If it is more than 5 per high power field, it is a leukocytosis. If it is less than 2, we say it is leukopenia. Here, one thing is very important. Sometimes the nucleated RBCs may be mistaken for WBCs in the automated analyzer. So, a patient who is having a hyperproliferative bone marrow and releasing a lot of young nucleated RBCs into the circulation, his automated report will show a huge leukocytosis, which is erroneous. So when we re-examine this blood as a manual smear examination, you can easily identify them to be RBCs and not leukocytes. I will not go into the details of the neutrophils. However, I must stress that neutrophilia, that is the higher percentage of neutrophil count, we have an idea that immediately we think that the patient is suffering from some kind of sepsis. But it should be stressed that neutrophilia can also occur in conditions where there is inflammation. One of them is the acute myocardial infarction. Sometimes, if the patient is on steroids, then there can be a high leukocyte count. He may not be suffering from an infection, but simply the steroid use inhibits migration to the walls of the vessels and leads to increased counts on a counter. It can also be increased in cases of leukemias. These two photographs show neutrophils with two lobes. So these neutrophils are called a Pelger-Huey anomaly. The Pelger-Huey anomaly is an inherited disorder which can be easily recognized from the smear examination. The other one at the top is a pseudo-Pelger-Huey anomaly, also found in cases of myelofibrosis or myelodysplasias. Next are the other types of leukocytes, the basophils, monocytes, and eosinophils. And I have enumerated the various causes which can lead to increased counts in each of these cell lines. Clues to malignancies. So, apart from various infections, inflammatory disorders, or hematological disorders, clues about malignancy can also be found from smear examination. As we know, the most important of them are the blast cells. So the percentage of lymphoid or myeloid blasts in the blood can make you or help you to diagnose a leukemia. Immature myeloid cells, various kinds, can be found in the chronic myeloid leukemia as well. Sometimes, if there is a paraproteinemia, you can see blood cells stacking up, and it is called a rouleau formation. So, the first figure shows myeloblasts. The second one demonstrates the rouleau formation, which is found in multiple myelomas. And the third cell is a lymphoblast. Of course, I understand, and I myself would not be able to recognize these cells. It will take the help of a pathologist to identify them for us, for physicians. But still, if we get such a report, we need not move around giving 1,000 investigations to a hapless patient and do focused and individualized ones. We have another case, a young boy who presents with weight loss, palpitation, and protrusion of his eyeballs for the last 3 months. This patient was referred to us as a case of probable hyperthyroidism from a BPHC where the thyroid function test was not available. However, on examination, we found that he had severe pallor, bilateral axillary lymphadenopathy, a normal thyroid on palpation, and hepatosplenomegaly. So this is a photograph, went for the peripheral blood smear where large abnormal looking cells were detected. These were actually myeloblasts. the bone marrow disorder, and this patient was suffering from an acute myeloid leukemia. Now coming to the third cell line, and which is very important during this season when we are having huge numbers of dengue cases, especially in West Bengal, and must be also in Orissa. So the platelets. So platelets, one platelet per high power field is equivalent to a count of 15,000 to 20,000 platelets in circulation. It is important to know this because in an automated counter, sometimes we can get a thrombus cytopenia due to clumping of the platelets. As I said, due to delay in examining the blood, that is the common condition. So true thrombocytopenia has to be detected and separated from pseudo thrombocytopenia. True thrombocytopenia occurs, as we all know, in causes of aplastic anemia, DIC, increased splenic sequestration, and thrombotic microangiopathies. Thrombocytosis, on the other hand, is a marker of systemic inflammation. It can occur in various autoimmune diseases and sepsis. However, again, another policy is that if there is too much fragmentation of cells, like neutrophil fragmentation or RBC fragmentation, as I showed the cystocytes, if they are present too much in the blood, then you can get an automated report of a thrombocytosis. And only a peripheral blood smear can help you to differentiate. I will. No, yeah, thanks, sir. So the last two slides is that infections. Malaria, filaria, and babesia. These are the three infections which can be easily diagnosed from a peripheral blood smear. So these are photographs of the C zones, ring forms, and gametocytes of the malarial parasite. So the take-home message is that a peripheral blood smear is a low-cost, simple procedure with easy availability. It is diagnostic in some diseases like malaria, CML, and sickle cell anemia. In other diseases, it gives a direction for further workup like nutritional anemias, malignancies, and other proliferative diseases. Some fallacies or errors in the automated counters may be corrected by cross-checking through a peripheral blood smear. So, thank you.
Thank you, madam, for this wonderful deliberation with very
Thank you, madam, for putting it such a nice topic because it is so basic that now that people are forgetting to do a diagram and they literally done the CBC. And there are two things you told here that the slide has to be examined within 2 hours, which is practically not possible.
Yes.
Because we stand the plot in the morning hour and get the report in the afternoon.
Yes.
Number two, many a times, even if we analyze the hemoglobin deficiency manually, they put it in a machine and do it a CBC test. Where there are many factors. I have seen many patients, platelet count coming as 17,000, 23,000, but we set the TPC, platelet count to do it in manually form. We get more than 1 lakh, those patients. And similarly, I have seen one experience, I have seen a patient in our unit where he do not have a pathologist.
full-time pathologists. They mostly do the CPC, and if you really seek for a very best job, we don't get it. Another thing, in the third case report you have mentioned that acute myeloid leukemia, you have then told the patient presented with palpitation and anemia, but the pulse rate you have mentioned is 96. So there was no tachycardia in this patient having anemia with the palpitation. He should have tachycardia, I think.
Yes, he should have, but he didn't. Maybe he was taken at rest, may have been.
Anyway, this is not a question, just my experience I told you.
Yes, sir. It is very important, and you are emphasizing what I was trying to say, that we should not ignore the peripheral bloods.
Actually, the EDTA actually clubs the platelet. That's why you see the pseudo thrombocytopenia, the EDTA samples. That's why the Coulter misses that. Coulter vision misses that. So you have to go for a manual count. Then you get a. But what may be the cause of high platelet burning mentioned? 13 lakh platelets, which no, what you mentioned. The 13 lakhs count was there in the machine, and later it came out to be 1.5.
So, the total application of the smear is lost, and small fragments by the machine are counted as one fragment. So, they can be a false report.
Thank you, Professor Nandini Chatterjee. I think
in the spare, peripheral spare. And another is after blood transfusion, what change occurs in the sphere?
After, sir, I'll take the second question first, is that sometimes after blood transfusion, there may be a dilution of the smear, and if we immediately take, are you asking that if we immediately take the blood after a transfusion, then there may be some fallacies or errors in the hemoglobin, MCAC and MCV, which is measured. So we should not do that, and we should give some time after which we could do, because the measurements can be erroneous.
I think we are running late, and thank you, Professor Chatterjee, for your fantastic talk. Thank you very much, ma'am. We'll go to the next topic, that is simplified glycemic care. For that, I invite Dr. Ritesh Kumar Agarwal. Dr. Ritesh is an endocrinologist from our city.
Good evening, all the delegates. At the outset, I will thank the organizing secretary for inviting me and the Olympic people who has given me the opportunity to speak on this August gathering. So, after discussing on the diabetes inflammatory markers, how it will helpful to see the phase to diagnose the different disease and to do the blood smear test, I will present how you will treat a diabetes patient in a simplified way, so that every patient will get the benefit of blood glucose control and to get the benefit of prevention of micro and macrovascular complications. So for that we make a sugar man. What is a sugar man and what we require? The sugar man has a high series uncontrolled or dual therapy, more than HbA1c of 1.5. High series, multiple medication, newly detected type 2 diabetes, obese. These are the presentations we have seen in our day-to-day practice. And we may say it is a sugar man. And what are the different patients? Multiple options we have. We want to see the good quality of life and the side effects of the different medicines. So, how we simplify the management of diabetes by selecting the best medicine with least side effect, with targeting major metabolic parameter to achieve the good glycemic goal. So, this sugarman requires a simplified glycemic care to achieve the different parameters. So, lot of options are available for the treatment, and we all know the different OHA and newer OHAs are also coming. Insulin, which option is suitable for which patient you have to find out, and lot of factors you have to take into consideration while choosing a OHA. especially the risk of hypoglycemia, weight gain, when to titrate, down titrate, up titrate, various comorbid conditions the patients have, young patient, elderly patient, CV benefits. So a lot of confusions are there while selecting the different type of OHA. So you have to choose a molecule with a better knowledge of least side effects, which will give the better outcome in your day-to-day practice. So we need to choose an option which is simple, hassle-free, lack of complications with major cardiovascular and renal beneficial outcome. So exploring with this, why we are discussing, if you see the incidence and prevalence of diabetes in India per se, more than 13 crore population will be affected with this diabetes in and around 2045, which is the projected scope. And if you see the Diabetes India Care Index, different states have their incidence and prevalence with around 9 to 10%, out of which 80% of our population have uncontrolled blood sugar, got the target of HbA1c of below 7. And maximum number of patients present with the eye complication, kidney care, diabetic nerve, heart problem, diabetic liver disease. So in spite of having lot of knowledge with lot of medications, still we are not able to achieve the HbA1c goal. So we need more simplified care to achieve that goal with least complications. So what are the causes of uncontrolled diabetes what we are facing in our day-to-day practice? Because of the ominous off-taste and the different pathophysiology which are not able to targeted by the existing medications. Different other diseases which is responsible for the hyperglycemia like the Cushing's disease, thyrotoxicosis, where we need to address this first. Poor compliance because of the multiple medications and number of comorbid medication, psychosocial factor and the clinical inertia which has to be targeted by both from the physician side and from the patient side. What are the different hormonal patterns you will get in diabetes patients which regulate the blood glucose and food intake? Insulin and amylin, GLP-1, glucagon and renin are the different hormones you will get. So in this discussion, we will more focus on the safest OHA, DPP-4 inhibitor, less risk of hypoglycemia, proven cardiovascular renal benefit, no weight gain, having better outcome in clinical practice. So this DPP-4 inhibitor are the incretin group of molecule which is secreted by the GI tract. GLP-1 and GIP which is inhibited by the DPP-4. So by DPP-4 inhibitor we will increase the half-life of the GLP-1 and GIP which act at the pancreatic beta cell and the other organ where the GLP receptors are there, which is the G protein coupled receptor. So they cause glucose dependent insulin secretion at the pancreatic beta cell, inhibit gluconeogenesis from the liver cell and act at the peripheral muscular cell along with the renal and the cardiovascular benefit. So this is the incretin effect which is reduced in our type 2 diabetes patient. If you see the insulin level in the control subject and in type 2 diabetes patient, there is a significant reduction in the first phase insulin secretion with the IV glucose and with the oral glucose. So this is a normal patient, but IV glucose will increase the insulin, but it is reduced in type 2 diabetes. That means the GI tract has some effect, which is additional effect of incretin, which is responsible for the blood glucose reduction. And how this DPP-4 acts, I have said, it inhibits the DPP-4 enzyme which is responsible for the short half-life of the GLP-1 which is around 2 minutes. And because of this, stimulate insulin secretion and suppress the glucagon secretion. So with these are the guidelines for by seeing the benefit of the DPP-4 inhibitor. Yes, if the comorbid conditions are there, there are some of the medications which are preferable. But along with that, if you are not able to achieve the target, in all the conditions, DPP-4 inhibitor comes after SGLT and GLP-1 if the compelling indication is there. But DPP-4 inhibitor you will find in all the column, either it is one or 12 or triple therapy, along with insulin also. So if you see the potential reduction in HbA1c,
with this group of medication, the DPP-4 inhibitor on an average of 0.5 to 1%, SGLT2 inhibitor, metformin and GLP-1 analog are this is the efficacy of the molecule. What I want to say to you, DPP-4 inhibitor will reduce around 0.5 to 1%. So how you will choose your DPP-4 inhibitor in your day-to-day practice? You have to see the efficacy of the molecule. If it is better, you have to choose. Dosing in comorbid condition, if there is no much contraindication or dose modification, it is better to give this molecule. Single daily dose of the molecule will increase the compliance for the patient. Cardiovascular data approved by the FDA. You have to choose and other side effects like hypoglycemia, weight gain. So these are the conditions you have to think before prescribing any of the OHA to your patient. So when we are discussing about the DPP-4, these are the different DPP-4 inhibitors available in the market, which is approved by the USA and Europe is the sitagliptin, saxagliptin, linagliptin and alogliptin. So how we simplify the care of diabetes management with the available molecule? If you see sitagliptin and metformin, they reduce the hepatic glucose outcome, they improve the gluconeogenesis and glycogenolysis, acting at the beta cell and acting at the insulin resistance by inhibiting the or improving the good adiponectin level from the fat tissue. So initial combination of this sitagliptin and metformin, it will target beta cell function both at the HOMA beta, that means improves insulin secretion, decrease HOMA IR at the peripheral level, improves insulin resistance, and there is also reduction in the pro-insulin to insulin, that means more active insulin is available in the blood circulation with this group of molecule. And if you see the efficacy, by metformin, placebo and the combination therapy, definitely compared to the monotherapy, combination therapy will be better to reduce the HbA1c, what we are seeing in this. Also, the HbA1c reduction, fasting plasma glucose reduction, and 2-hour postprandial glucose reduction with the monotherapy of the metformin and sitagliptin, and the combination therapy there is around 1.6 to 1.8% HbA1c reduction. And the lower percentage of patients require additional hyperglycemic therapy with this molecule when they are tested over a period of more than 1 year. That means it shows the durability of the molecule which is given with a single dose for more than 1 year, which is persistent compared to the metformin alone. The upper graph compared to the lower graph is a combination of sita plus metformin. HbA1c control is much better and it is persistent for more than 1 year, that is around 44 weeks. Long-term efficacy of the initial combination also over a period of more than 2 years. If you see the monotherapy versus the combination therapy, the lowest one showing the HbA1c reduction of more than 2%, which is persist for more than 2 years with the same dose of the therapy, which gives us a better idea about the molecule, better utility and less chance of decreased adherence because of the continuation of the same molecule. Which is also seen in the cosmic study where the responder of this group of patients with a longer follow-up data with treatment is well tolerated. And if you see the 4-year data, percentage of responders in last year is 72%, in 4 years is around 36%. That means a large number of population are responding to this molecule for more than 4 to 5 years. If you discuss about the sitagliptin per se, compared to the glimepiride and metformin also, if the baseline HbA1c here in this trial was taken around 7.5 to 7.6, over a period of more than 6 months, the HbA1c reduction potential of this molecule is at par with the glimepiride and metformin with lesser risk of hypoglycemia and lesser risk of weight gain. It provides an HbA1c reduction at par with the glimepiride if the baseline HbA1c is below 7, 7 to 8, 8 to 9 and more than 9. Definitely with the higher HbA1c we will get more HbA1c reduction with the sulfonylurea in the initial phase. But with the lower HbA1c group you will get the same amount of HbA1c reduction over a period of 6 months. Those group of patients who are on sulfonylurea metformin, here you see the HbA1c reduction. When you are adding sitagliptin to the existing combination, you will get more HbA1c reduction over a period of 6 months. Definitely because of the dual therapy and the triple therapy, we will get more HbA1c reduction. But weight gain potential of the glimepiride and sitagliptin, definitely you will get the weight neutrality effect of this molecule over a sulfonylurea group, and the risk of hypoglycemia you have to be take care while selecting this group of molecule to decrease HbA1c, especially in newly diagnosed cases or struggling cases, in elderly population, and where the comorbid condition are there, where the use of sulfonylurea is contraindicated. In the superior efficacy trial also, where they have compared with the sitagliptin monotherapy in terms of HbA1c reduction, change in HbA1c, fasting and postprandial glucose response to the meal also, this was decrease in the both fasting and postprandial HbA1c reduction. In add-on therapy to insulin also, initially you have to reduce the dose of insulin by 10%, and you will see there is a change in the HbA1c reduction compared to the placebo, change in the fasting plasma glucose, change in the postprandial plasma glucose. So more efficacy compared to the placebo as a monotherapy, as a dual therapy, as a triple therapy, and as an add-on to the insulin also. So same molecule, no hypoglycemia risk by seeing the benefit of the molecule, but you have to be cautious while you are adding with sulfonylurea and insulin, and lesser risk of hypoglycemia. Now, the triple combination therapy of the SGLT2 inhibitor, sitagliptin, and metformin is available. And if you see the cardiovascular outcome trial with this in diabetes, where overweight and obese patients are there, more than 70%, they are hypertensive, they are dyslipidemic. So, SGLT2 inhibitor is one of the molecules which will target this overweight patient, able to reduce some form of hypertension, and also have favorable outcome in the dyslipidemia. So, combining these three molecules, you will get the better outcome in the cardiovascular risk reduction. And here you see the cardiovascular comorbidity, obesity, hyperlipidemia, and hypertension. Around 20 to 30% of our patients having all the three comorbid conditions. So we need to give a molecule which will target not only the blood glucose level or the HbA1c. This metabolic parameter are also to be taken care of while selecting a molecule in the management of diabetes. So we all know diabetes is a cardiovascular disease risk, where you see the no prior history of MI, prior history of MI in non-diabetic versus no prior history of MI in diabetic population, which is equivalent to a prior MI in non-diabetic population. So a major bunch of our diabetic populations are at risk to develop the myocardial infarction. And because of that, the paradigm shift in the management of diabetes has occurred, where glucocentric approach has changed to the metabolic centric approach, where a person is treated, not the blood glucose treatment is required. And because of this, as I have said earlier, if some of the compelling indications are there, we need SGLT2 inhibitor, GLP-1 analog. Along with that, DPP4 inhibitor are also a safer molecule in this regard. So the combination SGLT2 inhibitor and DPP4 inhibitor, these are the pathogenetic way how they will target the ominous octet, and around 6 pathway of the ominous octet are targeted by these two group of molecules. And here you see the combination therapy here important is when if patient is on DPP4 inhibitor and metformin, you are adding SGLT2 inhibitor or switching them. So addition is favorable compared to switching the patient, and in terms of all the cardiovascular outcome trial, all-cause mortality, 3-point MACE, hospitalization for heart failure. So cardiovascular effect, we all know about the examine trial, Libertini trial, DCOS trial, Carmelina trial. So sitagliptin and linagliptin non-inferior, but in terms of the 3-point MACE and the all-cause mortality, saxagliptin and elogliptin is also shows the non-inferiority, but in terms of hospitalization for heart failure, definitely saxa and elogliptin falls behind the sitagliptin and the linagliptin. Sitagliptin designed for the cardiovascular safety, they shows these are the parameters: hospitalization for heart failure, fatal, non-fatal MI, hospitalization for unstable angina. There is a reduced risk reduction with this group of molecules. DAPA CKD trial for the SGLT2 inhibitor dapagliflozin has shown the beneficial effect in terms of end-stage renal disease in the primary outcome and shows secondary outcome reduction of around 20% in the secondary and renal outcome. SGLT2 inhibitor, the proposed mechanism of action for renal protection is by decreasing the intraglmerular pressure, decrease the oxidative stress, and decrease the fibrosis occurred in the proximal convoluted tubule. And also there is a systolic diastolic blood pressure reduction after baseline and after 3 months. Additional clinical benefit as an add-on of dapagliflozin where you see sustained reduction in the glycemic parameter in body weight with no risk of hypoglycemia over a period of 1 year. And combination of this fixed-dose combination in a meta-analysis which favors the combination over the monotherapy in terms of the incidence of genital mycotic tract infection. Though postulations are there, but the data says the combination is less causing mycotic genital tract infection compared to monotherapy alone. So targeting multiple pathophysiology of the ominous octane is the need of the hour, where we will target the major pathophysiology to get the benefit in different way. Controlling ominous octane with the multiple pathophysiology should be targeted. Early initiation of combination in drug naive cases where it is needed is giving an intensive control. Most percentage of patients will achieve the HbA1c goal with lesser risk of comorbid condition. Combination therapy include multiple drugs with different mechanistic actions, showing the synergistic mechanistic action. Diabetes management demands not only blood glucose lowering but also delaying the disease progression. So these are the ominous octane and these are the different pathway where we can target with the different molecules. I am not going to detail, but this is the slide where with all the OHs are available which will target the different pathophysiology of the ominous octane. So to summarize, holistic therapeutic management is necessitated the understanding of the pathophysiology, delay the disease progression with the different drug classes by targeting the whatever the data is available for the pathophysiology is the need of the hour. DPP4 and metformin are guideline recommended drug. Among DPP4, sitagliptin has a favorable outcome in all form, either it is reduction in inflammation, beta cell insulin secretion, HOMA-IR reduction, and in the peripheral level of improving the good adiponectin. Sitagliptin is well tolerated and you can prescribe in the hepatic mild to moderate cases, renal impairment with dose reduction with less than 45. Sitagliptin shows highest benefit risk ratio in the effective management, and the strategy of early combination of this group in patients with newly diagnosed type 2 diabetes significantly and consistently improve the long-term glycemic control and comorbidity, which has been also taken by the ACE guidelines where the HbA1c is more than 7.5 without any symptoms of osmotic symptoms. You can start with the 12 triple therapy. So thank you for your kind and patient hearing, and thank you the organizer for giving me the opportunity.
Dr. Ritesh, for this wonderful talk. I think there has been some message from the committee that we have to stop the program because the ceremony, that inaugural function will start. So if you can take some quick questions from the audience, or we can wind up.
So before starting the question, I on behalf of the Endocrine Society of Odisha 10th year, I am also inviting to all the August gathering to our conference, which is going to be held on the 27th, 28th, 29th October in the Swastika.
One important thing I would like to tell, there are, though all DPP2 inhibitors are there are multiple, there are definitely intrinsic molecular differences which goes more in favor of sitagliptin. Secondly, I would like to point out that the last ADA, Defender himself revisited his own talk of multiple hit pathology, and he strongly suggested not mono, not sequential mono, it is combination and combination. So that is again second third one. Another very important point is Asians specifically have DPP enzyme activity highest in the world. So we respond much better to DPP more than that. Another fourth important point is whenever you give a combination of SGLT inhibitor along with the DPP inhibitor, the greatest advantage is one is glucagon reduction and the other one is glucagon increase. So it will counteract both actions. And the fourth advantage is the mitotic infection is definitely reduced when you combine because DPP4 enzyme itself is used by the organism of the mitotic infection. So these are the great
Points are rightly taken, and here I will highlight 2 points what sir has said. Combination therapy is what the data says is always better than the addition of the second hardline molecule from the beginning. We Asians are more responding to the DPP4 inhibitor compared to our counterpart of the Caucasians. There are impulse of hypothesis for that. One is the tryptophan hypothesis, one is the more we insulin resistance, and one is the lack of the adiponectin, good adiponectin, but the DPP4 inhibitors are showing much better response in our Asian population. All other things are also well taken. Thank you, sir. Thank you.
Any further question can be taken up by with the cup of tea. It was session here because of lack of time. Thank you very much.
Invite the speakers and all the speakers to come to the dais for registration.
I would now like to invite Dr. Sanjay Arora sir to felicite the speaker and the chairpersons of the session. A moment, a token of our gratitude.